A very good morning to all my respected seniors, friends, and colleagues. On behalf of the Infertility Committee AMOGS, Maharashtra State Chapter of ISAR, and Nagpur Obstetrics and Gynecological Society, I, Dr. Kalpana Jetha, welcome you all to this pre-Diwali academic feast. Today, we all have gathered here to expand the horizon of our knowledge and learn the new and changing trends in infertility. We also have the release of the book Change, which has been written by many of us. I now welcome our very own dynamic and ever enthusiastic Dr. Chaitanya Shembekar sir for the welcome address. Sir is the chairperson of the Infertility Committee AMOGS and the past president of NOGS. Over to you, sir. I welcome you, sir.
Thank you, Kalpana. Uh, Dear friends, a very good morning to you all. I welcome you all for the new normal, the webinar on changing trends in infertility. Every creature in this world adapts to the changing environment, and we humans, by virtue of our wisdom, are the quickest to do so. Thus, as we face this unprecedented challenge of the highly contagious and extremely lethal virus, we had to find out ways to get our life back to track after a brief hiatus. As Stephen Hawking famously said, intelligence is the ability to adapt to change. In order to meet the challenge of COVID era, we had come up with guidelines of changing trends in ART practices as early as April this year. I'm sure this book has helped many of practitioners to steer their fertility practices in the right direction given the extraordinary situation. Today I'm happy to announce the release of hard copy of this book Change, and I'm grateful to all those who have contributed towards its making. I am aware of the fact that every organization needs funds, which are few and far during this pandemic. I am happy to make a small contribution from Omega Foundation towards AMOX, MSR, and Nagpur Gynec Society. The webinar today will focus on all the newer trends which have become the norm, and hence the theme, the new normal. We are indeed fortunate to have galaxy of star speakers, and I'm sure that we will be an enriched lot after today's deliberations. Thank you very much. Thank you.
Thank you so much, sir. I now request Dr. Nandita Palshetkar ma'am to kindly say a few words. Ma'am is the president of AMOX and the past president of FOXY. I welcome you, ma'am.
Thank you, Kalpana. I think, first of all, welcome everybody to this platform of Amongs. And I've got one very dynamic chairperson, Chaitanya, who's been doing a lot of work. And also, when we started in the COVID, in March, we all were told to shut down our clinics. And then came the thought process that we all need to start back our work. And that thought came to me, and we had a lot of organizations, the ESAR, working towards it. And I was talking to Chaitanya, and we decided that Maharashtra, especially with so many IVF specialists, that we should have a kind of a guideline, OPDs, IVF centers, etc., etc. And I must say that Chaitanya took this initiative, and along with Nilesh and Rohan and Rishikesh, they actually ran with it, and they got contributions from so many people. But one of the best things that happened was my dear friend Sunita. She collaborated with us, and it was a fantastic effort on AMOGS and MSR. And I think this is what we gave back to the IVF specialists of Maharashtra on how to start. And it was very important because all the guidelines so far were saying that, you cannot do IVF, you should stop and all. So it was a stepping stone to get we were all in financial crisis. There were patients who were crying out for treatment. So I think this book, or these guidelines which were formed, were actually a stepping stone for all the IVF specialists. In fact, not only in Maharashtra, everyone around the country has actually thanked us for doing this. And I think MCure, thank you very much. You've played a very important role, and you're, just distributing the hard copy. Whatever you say, we are the generation I've got another webinar on air pollution, and I'm busy making notes. We are the generation, not the digital generation. We like our books, we like our hard copies. I love the smell of paper, So I'm very grateful and very happy that you have come forward and, contributed this, aspect to seeing that all the IVF specialists all across the country actually get this. And it's beautifully written with lovely infographics and very, very practical point to point, the SOPs kind of to give everybody. So congratulations once again, team of the Fertility Committee of Infertility Committee of AMOGS and MSR. I'm really grateful, and we're doing this. And I think I can see all my friends over here. Now I'm on this full view, so I can see Mandakini, Rajiv, thank you, Kishore, Murray, Kalpana, I think you did a wonderful job. Nalini is one of my dynamic AMOGS person. Sudesh really helped us with all the, the embryology part. Then Sneha is there, Sneha, dynamic person. Who I don't know whom I can see. Amay, oh, hi, welcome. Thank you, Amay, for the first input which we did for COVID instructions for the government of Maharashtra. Nilesh is there, Rohan is there, Amrita Tandon, and I think there are lots more. So I will just end here so that you can get on with the program. And congratulations, Chaitanya, for doing such a, creating such a dynamic program and all the webinars during my year. So thank you very much. And I'd like to welcome all the other guest of honors. I think Rishikesh and Sunita. Have I missed someone? Alpesh will be joining us a little later. Thank you.
Thank you so much, ma'am, for your encouraging and kind words. We always acknowledge your charming presence with us. Thank you so much, ma'am. I now welcome Dr. Sunita Tandulkarkar, madam, to kindly say a few words. Ma'am is the chairperson of the MSR and the president of Indian Association of Gynec Endoscopy. Over to you, ma'am. Sunita, madam. I welcome you, ma'am. Hello.
Ma'am, I think somehow ma'am has logged out for some reason.
Okay.
Her internet must have gone.
Okay. She's come online.
Okay.
Congratulations, first of all, you're doing a huge job. I still remember when you called up, can we do this guideline? Can we have a MSR joining with AMOGS? And Nandita being a president of AMOGS, we both search every opportunity to collaborate. Even when I was a IAG president and she was Foxy president, we wanted to do one program together, and her vice president, Ashwath, being an endoscopist, we just got the occasion to join with each other. So it's always lovely. Rishikesh, Amay, don't give me that smile, okay? I can see all of you. I made a gallery view. Samayji, thank you so much for joining. EVA division is doing a wonderful, wonderful job with Rajiv and little bit naughty Kishore Mule. It's a fantastic work you people are doing it. I think Rishikesh and Chaitanya, I don't know who has made this. Today's program is fabulous. But one thing I would like to say is your contribution of a foundation to donate for the organization. See, it's very important. Nandita spoke all most important thing, which was really reflection of my mind and my thought process. But one thing I always believe is we all live in the heaven, and God sends us on a vacation on the earth. Some people get 10 years, 20 years, 50 years, 70 years. Everyone has their own destination, but we have to go back, and God will ask us, have you enjoyed your vacation? Have you given any footprints of yours on this earth? And these foundations are the one which gives us an opportunity to leave our footprints on this earth. So we are going khali haath aaye hai, khali haath jayenge. What we are going to take is our karma, and what we are going to leave is our footprints. So your foundation, every academic partners which we join, indirectly they are contributing because they are giving us academics. They are teaching us how to optimize our results in our day-to-day practice, and then we give those babies and we get the duas. No other profession can get what we can get. We not only give a life, we give a lives, we give a happiness, we make our footprints with our foundation. So it's very, very noble thing you are doing by donating some amount to the organization. Thank you for this kind gesture. Thank you.
Sunita, good you brought me to, reminded me of this. Chaitanya, this year Amogs has no earning because we've cancelled the annual conference. Okay.
Yeah.
So all this money, and you know, in Amogs, we've not made it compulsory. We've made it voluntary, and all my people have really contributed, even small amounts. And I think it helps the organization in a long way. So thank you very much. Hi, Samar. Good to see you after long.
Good. Welcome,
Okay.
Alpesh, sir.
Alpesh has come?
Good morning, Alpesh, sir.
Alpesh.
Kindly unmute, sir, please. Amit.
Good morning.
Good morning, Alpesh.
Hi,
So good to
Alpesh.
see you. You're jumping from one platform to the other. Rishikesh said you're more busy than Modi also.
No.
You're doing an amazing job. So welcome. Yeah, Gayatri, you can take over.
I think Gayatri, you should call Dr. Alpesh now before we call others. No?
Kalpana, sorry, not Gayatri, Kalpana.
Kalpana, sorry.
Yes, sir.
So shall we release the book and?
Yeah, Alpesh has come. Let's do that.
Yeah.
Okay. So I now request all of you, Dr. Alpesh Gandhi sir, Dr. Mandakini madam, Sunita madam, Rishikesh Pai sir, and Nandita madam for the opening ceremony of the book. I request the editors of the book, Dr. Chaitanya Shembekar sir, Dr. Nilesh sir, and Dr. Rohan sir to please join.
Well done.
Rishikesh, start opening.
Yeah.
Alpesh, have you got a book? No.
I have received book at my hospital and at present I am from my home.
Oh,
Okay.
I have received it, yes, but
We will assume, sir, that you are opening the book.
yeah, thank you.
all right. So,
On my behalf, Nilesh is opening the book.
Foxy representative.
Yeah.
Chaitanya, your virtual background is hiding your book.
Vaidehi, welcome Vaidehi. Vaidehi, you also join us. Vaidehi has joined.
Hi, Vaidehi. So congratulations.
Congratulations.
Thank you.
Congratulations to all the contributors and editor of this book.
Congratulations, Chaitanya, to you as well.
Thank you so much.
Congratulations, sir.
Welcome, Madhuri madam.
I think
Dr. Madhuri Patel has joined.
Vaidehi
Dr. Vaidehi
joined.
Marathi has joined.
can you request Dr. Alpesh Gandhi to say a few words?
Yes. I welcome the President of Foxy, respected Dr. Alpesh Gandhi sir, for the inauguration. I also request Dr. Alpesh Gandhi sir to throw a light on today's function.
Thank you very much for giving me priority and giving me this opportunity and giving this honor to me. Dear friend Nandita Palsetkar, guest of honor, today's guest of honor, Nandita Palsetkar, past President Foxy, Rishikesh Pai, President-elect Foxy, Dr. Mandakini Meg, Chairperson ICUG, today's convener Dr. Chaitanya, co-convener Dr. Nilesh and Rohan, and today's speakers Dr. Amit, Dr. Madhuri, Dr. Rishikesh and Chaitanya, and all the chairpersons, Dr. Vaidehi, Sneha and Lakshmi, moderator Dr. Manish and Jaideep, and all the panelists. A very good morning to all of you. At the beginning, I would like to congratulate Infertility Committee AMOGS, MSR, Nagpur Obstetric Gynecological Society, and AMOGS for this wonderful work. You people are doing amazing work. Continuously, I am getting flyers and I am knowing activities of AMOGS. AMOGS is doing lots of activity, and it is good that Nandita is free to do lots of work for AMOGS. And I must congratulate for continuing good academic work during this difficult time of COVID-19. And I also would like to salute all of you because you all are Corona warriors. 70% of the patients infected with COVID-19 are asymptomatic, and we do not know when and how we will come across in contact with them. And even though we all are continuing our good work for the women of India, and so I must congratulate and salute all of you. You all are great Corona warriors. Today we have very new normal in infertility and so good topics, very eminent faculties. I would also like to attend, but as you know, we have one more webinar from 10:30 onwards to 6:30 on imaging in obstetrics, advanced imaging in obstetrics. So I would have to leave earlier. I wish grand success to this webinar, and I wish great learning, happy learning, safety to all the members of HEMOX. And in advance, I wish happy Diwali to all of you. Thank you very much once again for giving me this opportunity and honor. Thank you.
Thank you so much, sir. We acknowledge your presence in today's event in spite of your busy schedule. Thank you so much, sir.
Alpesh, we are following in your footsteps.
No, I am following in your footsteps.
The king of webinars, yeah.
I would like to take one more minute.
Yeah.
Can I take?
Yes,
Sure.
On 22nd November, it's a Sunday. Foxy has organized a very big event that is on No to Violence to Women and Girls. And we want to take it on a very, very big level, a mass level. It will be a community connect program where we are going to discuss so many things: violence in childhood, violence at harassment at workplace, then acid attack and domestic violence and sexual violence and safety tips and so many things we are going to discuss. And we invited eminent faculties across India, some of the lawyers, some of the judges, police commissioner, celebrity. We are trying to invite all of them for this webinar, and let us show our unity, solidarity for this cause across India, and let us try to reach to each and every corner of India. I wish all the societies participate in this mega event, and all the Foxians also participate in this mega event. And please circulate this flyer. We will send it soon, the flyer and details to all of you. Please circulate it to all your friends, relatives, patients, whomsoever you are knowing. Please circulate it to all of them. School, colleges, everywhere, Rotary Club, wherever is possible, please send it to this and try to take the Fox's vision across India to each and every corner. Thank you very much for giving. Thank you.
Thank you so much, sir. I request Dr. Mandakini Make Madam to enlighten us with her words. Ma'am is the chairperson of the ICOG. She needs no introduction. Mandakini Madam. I welcome you, ma'am.
Mandakini, welcome. I think you're Maharashtrachi Mulgi. Please go ahead.
Morning to all of you. A very pleasant this pre-Diwali. I can see all dear friends. Good morning, Dr. Alpesh Gandhi. Going from one webinar to another. First of all, I'd like to thank Dr. Nandita, Dr. Sunita for organizing such a wonderful program and inviting me as the guest of honor. Also, my great congratulations to Dr. Chaitanya Shembekar for organizing this new normal. I think we all have become used to this new normal. And we gynecologists don't want to go to the other normal. Now this has become our new normal, and we are reaching to so many people. You can see Dr. Alpesh Gandhi doing the fantastic work. Even our Nandita going beyond the Maharashtra. Most of the programs are with collaboration with MSR, IAG, even for the ICOG, Foxy. So fantastic work. Here I'd like to say that Chaitanya has just, released the book of this Changing Trends. That is a changed book of the ART practice during the COVID era, and which is going to be really great and very helpful. I just seen the book and released the book also. we all have become used to this new normal. And I think the telemedicine, telecounseling, and the teleconsultation is the new normal. Whenever I contact Rishikesh, he is always in the foreign patients, he is always in the teleconsultation. So all my friends are actually practicing. And here I want to say, as a government person also, that even the MT peoples are being given on the allowed to give in the teleconsultation. That is a very good thing. We are progressing very well in this era. And the last comment I'd like to say that at ICOG we have around 50 reproductive medicine center, and we are having around 52 or 55 fellows every year doing this reproductive medicine course of 6 months. And as soon as the COVID was declared, I was the first to jump into the online classes of reproductive medicine. Dr. Madhuri Patil is here. She is the convener. And we, Chaitanya, Lakshmi, Sunita, they all are our faculty. And it has become extremely most successful program. Now it is in great demand. Everybody knows it. We are going to start this program from 17th of November again, this season 2. And I told Rishikesh when he came that with attending 36 lectures, being with the infertility specialist, now I want to open the IVF clinic. So please help me in, because now I know everything now. And Madhuri Patil is teaching me time, everything. So anyway, so nice to be in the, amidst of all. Changing trend has become the new normal of the online classes, and fantastic work. So I again congratulate Dr. Nandita. Beyond Maharashtra, I can say beyond Maharashtra, going all over India. MSR, Sunita, a fantastic. Last Sunday also we met. You gave a fantastic oration. She was in love with somebody that I don't know who, but she was giving that oration, and I think
everybody is doing endoscopy only. It was only endoscopy.
Everybody knows that.
Anyone else other than that.
So all my friends, I just want to mention everybody's name: Ameya, Vaidehi, Amit, Madhuri Patil, Kishore, and Nilesh, Sneha, Amit Borse, Sudesh, a fantastic work. Rohan, all the new. So thank you very much for inviting me. Like Alpesh, I'm jumping to another 2 programs. So thank you very much and all the best for this program.
Thank you so much, ma'am. We always acknowledge your kind guidance and encouragement and support to us. Thank you so much, ma'am. As my mentor, Dr. Shembekar sir always says, change is the only constant in life. So today we all have gathered here for release of the book Change, that is Corona Handling by all infertility experts. I now request Dr. Rohan Palshetkar sir to acknowledge all the contributors of the book.
Thank you so much, Dr. Kalpana. Firstly, I must say that I have to thank each and every contributor that has taken part in this, mainly with the fact that they gave us their chapters within 2 days and 3 days itself, helping us get this book together. Obviously, I also need to thank Dr. Chaitanya Shembekar sir and Dr. Nilesh Balkawade sir for mentoring me through this entire process, teaching me how to get along with this book and everything regarding all the authors. So without taking too much time, I'm just going to quickly read out the names, the contributors, and this. Obviously, Dr. Nandita Palshetkar, thank you for your guidance and the opportunity to do so. She's the president of AMOGS and past president FOXI. Dr. Rishma Pai, president of the Mumbai OBGY Society, past president FOXI. Dr. Rishikesh Pai, president-elect FOXI. Dr. Sunita Tandulwadkar, chairperson MSR. Dr. Amit Patki, Medical Director of Fertility Associates and General Secretary of MSR. Dr. Arun Nayak, Secretary of AMOGS. Dr. Padma Rekha Jirke, the Editor-in-Chief of ISAR Journal and the past Secretary of MSR. Dr. Jaideep Tang, Secretary General FOXI. Dr. Chaitanya Shembekar, he's a consultant in Nagpur, Chairman of the Infertility Committee AMOGS and past President NOGS. Dr. Nilesh Balkawade, he's the member of the Infertility Committee AMOGS and he's the National Coordinator for FOXI Quiz Committee, and now he's, I think, the chairperson-elect as well. we'll just move to the next slide, thanks to me as well. But Dr. Lakshmi Srikhande, she's the chairperson-elect of ICOG. Dr. Varsha Baste, an IVF consultant in Nashik, executive member of MSR and chairperson of the IAEC committee of FOXI. Dr. Hitesh Bhatt, the advocate and medical legal consultant in Mumbai. Dr. Kundan Ingle, FOXI Infertility Committee Chairperson. Dr. Pardesi Sir, he's the Vice President of AMOGS and the past Vice President of FOXI. Dr. Paresh Gandecha Sir, the Consultant IVF in Yavatmal. Dr. Sadhna Patwardhan, Consultant IVF Nagpur and Librarian MSR. Dr. Veena Panath, past President Aurangabad OBGY Society. Dr. Parul Sauji, Consultant IVF in Nagpur. Dr. Kalpana Jaita, an IVF consultant from Nagpur. Shraddha Patil, an IVF consultant from Jalgaon. Dr. Milind Patil, an IVF consultant from Solapur. Dr. Sushma Deshmukh ma'am, President of the Vidarbha chapter of IFS. Dr. Sangeeta Tajpuria, Treasurer of Nagpur OBGY Society. Dr. Shilpa Sood, the past President of the Vidarbha chapter of IFS. Dr. Prerna Shinde, the Organizing Secretary of Shirdi MSR and Consultant IVF in Ahmednagar. Dr. Amrita Tandon, IVF consultant and member of the AMOGS Infertility Committee. Dr. Aditi Tandon, IVF consultant and member of the AMOGS Infertility Committee. Amok Chimote, consultant IVF from Nagpur. Dr. Balasaheb Kharbade is a member of the Infertility Committee, AMOGS, and a consultant in Navi Mumbai. Dr. Manjari Velsankar, she's an executive member of MSR. Dr. Darshana Pawar, IVF consultant from Nagpur. Dr. Ashwini Kale, a treasurer of MSR. Dr. Sudesh Kamath, he's also an executive member of the MSR and the embryologist of Bloom IVF. Dr. Pratik Khede, an IVF consultant from Nagpur. Dr. Kiran Kurtakoti, a vice president of AMOGS and IVF consultant from Pune. Dr. Sujata Dalvi ma'am, joint secretary of AMOGS. Dr. Pipin Pandit sir, AMOGS treasurer. Dr. Amaya Purandre, state coordinator, AMOGS. Dr. Kalyan Barmade, treasurer of IAG. Dr. Nalini Bagul, she's the IVF consultant from Nashik and organizing chairperson of the AMOGS annual conference. Dr. Manjushri Boob, she's also executive member of MSR and consultant from Amravati. Dr. Ashish Kale, executive member of IAG and past treasurer of MSR. Dr. Bindu Chamote, embryologist from Nagpur. Dr. Jailam Deshmukh, the consultant of Akola. Dr. Umesh Savarkar from Amravati. Dr. Rohini Deshpande, ma'am, immediate past president of AMOGS. Dr. Shalaka Mamidwar, consultant IVF from Chandrapur. I think we're done with all the contributors. These were the 50 contributors who actually took part so energetically and made sure that this book got released in time. I think Dr. Chaitanya sir, Nilesh sir, and I contacted all of them, and within a week's time, we had all their chapters in the flow charts, everything properly given to us. Honestly, it made our work a lot easier to compile the entire thing and make the anime this. And you can see what a wonderful book we've come out with. And obviously, we also need to thank MCure for helping us with the entire book and getting this all together. So thank you so much.
I think congratulations. You all have done a wonderful job. Fantastic.
Thank you.
It's really, really a great pleasure to release this book.
Thank you so much.
Yeah, I think Amit is talking. So, okay. Yeah, please go ahead.
Yeah, thank you so much, Rohan sir. Funds will always help us, and they'll always be needed for equity and have an important role in providing liquidity to a financial system. I now request Dr. Rishikesh Pai sir for handing over of the checks to the various organizations and MCure also. Dr. Rishikesh Pai sir.
Yeah.
I also invite sir to please say a few words and guide us regarding today's program.
Yeah, Kalpana, I would like to present the checks before Dr. Rishikesh Pai gives his address. This is a small contribution towards 3 organizations, that is AMOGS, MSR and Nagpur OBGY Society. We through Omega Foundation, we are giving a check of rupees 15,000 each to the 3 societies. And along with this, MCure has also promised to give funds of rupees 10,000 each to the 3 societies. So this is a small contribution towards organizations from our side. And thank you for accepting these checks, Nandita Madam, Sunita Madam, and Vaidehi. Thank you.
Chaitanya, really we appreciate this gesture and how you combine the release of a book with the foundation, the academics, everything you got into one basket, you know. It was a really fantastic gesture of this, especially in this. And you not only did with your foundation, you asked Eva also to do certain contribution. This was more appreciable. That shows your love to everyone.
Thank you. Thank you.
I have Amit here. I saw Amit.
I know. I also saw him. But
our treasurer is absent, but Nandita is here. Nandita, you would like to say?
No. I'm absolutely happy, and you know, it's all voluntary done work for the donations given by my Amoxians, and that is something which I really appreciate. So thank you very much, Chaitanya, and keep up the good work and give us lots more money.
Thank you, madam. Sure.
Thank you, Chaitanya sir.
Madam, could I say a word, please?
Yes, sir.
Yeah. In one of Dr. Nandita's objectives this year as AMOX president, she had said that we need to ensure that adequate educational grants come into AMOX so that all this could be used not just for academics, but even for community work, etc. So we should appropriately call them as educational grants and community service grants rather than just call them funds, because they have such a noble gesture and thought behind them.
Right.
Thank you.
Yeah, thank you so much, sir.
I think we should be Rishikesh now. Let's hear his words.
Yes, Rishikesh Pai, sir. I welcome you, sir.
Hi. So I don't want to say too many things because we are already delayed a little. And of course, acknowledge the three main important people who are there, 3 or 4 of them. Dr. Nandita Palsetkar, who is the AMOX president, the Sunita, who is the MSR chair, and Vaidehi, who is the NOGS president at present. All are very dynamic ladies. And of course, one man whom I have really seen grown in size a lot over the years, and that is Chaitanya Shammekar. From a small practitioner, he has really become larger than life and has really created an impact in the whole Nagpur area. And I feel that many of the Nagpur the leadership will come to the national level also. They are very highly capable, and I think it's high time they all started looking at coming to the central leadership. And of course, our funders are there. MQR is always there with us. Samar Rajiv and all his team is there. And all the Dr. Mandakini, our ICOG chair at present, and Alpesh Gandhi, who is of course been our Foxy, very dynamic Foxy president. And then all of you are there. I mean, I don't want to take your name, but you know that you all are in my heart, because if I start taking the name, then we'll not. Only thing I would like to tell you is that when this was started, there was, the controversial area of egg donation and surrogacy. So because some of the organizations were totally rigid about third-party reproduction being mentioned also in the answer. But if you, then, we came across the British Fertility Society where they were very liberal, and we must actually follow the British law. The British people are very, very just, and they look at everything very properly. And then I was called to be on the ICMR committee, and only yesterday the final document has come to me on the email to give my final okay. We are 10-15 of us on the committee, but just imagine we are already out with our document. Of course, Dr. Sharma was delayed because he was busy procuring the kits for the RT-PCR. And one of the points he made, and this point I think I should tell you all that. He was saying that when he was put in charge of acquiring the RT-PCR kits from abroad, each kit was costing nearly 1,800 rupees, and the last kit order he gave was at 37 rupees per kit. So he said that look at the amount of margin that is there, and he urged the committee that at that point in time in Delhi that we should start looking at manufacturing disposables on our own, because the amount of revenue loss that is there for the country is huge. Just imagine what the margin was. So anyway, this was just by the way. So coming back to the conversation, so I hope this book will go all over. And in this book, and in the ICMR committee recommendation, the donor and third party reproduction was there. So I was very happy because it vindicated our stand that we wanted to also include donors and third party into our our guidelines. So this is our guidelines and their guidelines is nearly the same. So I'm very happy about it. It's still not come, but it will come now. So I'm very happy for every one of us. And I'm very happy that Chaitanya has donated so much money. This is very also important. Money is very important for the organization. And what we have to learn from this COVID experience is that we have to be self-reliant. And ultimately, we have to contribute our own money and enjoy our own life. We can't all the time depend on others. So let us start looking from that angle in the future. Let us all contribute and spend. So when we contribute and we spend on ourselves, no one can object to anything that we do. So we also develop a lot of self-respect. So anyway, thank you very much for calling me. Before I must acknowledge Madhuri Patil. She has been my classmate, and one of the things I would suggest to the various MOX and MSR and all, you have to pull her back from Bangalore. She is actually from Maharashtra but gone to Bangalore. She is a major asset, very intelligent person, very hardworking, sincere, dedicated, and asset to any organization. So I hope that we can also pull her back to Maharashtra from where she originally is. Anyway, thank you very much all. You all are in my hat, and thank you. Many of you are there, Nilesh, Neha, Rohan, Ameya. I mean, I can't go on and on. Thanks a lot.
Thank you so much, sir. Thank you for your kind words and your valuable experience, sharing your experience with us. Thank you so much, sir. I now request Dr. Nilesh, sir, to propose the vote of thanks.
Nilesh, before you do that, give honorary membership to Madhuri. Rishikesh has proposed it, of AMOX.
AMOX president and MSR chairperson are there, so they can consider this, I think.
Still a member of, I was a life member of Mumbai OBGYN Society. So anyway, I'll be a member of AMOX.
Yeah. So we give you honorary membership of MSR then.
Not associate membership, honorary membership.
Yeah, that's also a good idea.
Nandita ma'am, we can start a Ghar Wapasi initiative.
Yeah, now I'm old enough.
We must forget Sudesh also, one of the few embryologists who is representing us now on the board.
Yes.
But he is doing a lot of academics and everything. The other day I had some question. I called him up. He gave me all the details about microfluidics and all. So I'm really happy to have Sudesh on my team.
So at this juncture, I'm speechless to see all the stalwarts from Foxy, from AMOX, from MSR being present here. I can just but say Sanskrit shloka, Mahajano yenagataha sa sanmargaha. We are just trying to follow you. We are just trying to imitate you and trying to be there where you are. I suppose that it's too early and too difficult for us to get there because you have set standards for all the organizations where you have led. Like we have seen Nandita madam leading Foxy. We are now seeing Rishikesh sir, Sunita madam being in a newer role in Foxy. So we are seeing all of you there. So thank you all of there for guiding us through all these times. I also thank President Foxy, Dr. Alpesh Gandhi sir, for sparing his time and releasing the AMOX change booklet. I also thank the guests of honor, Dr. Rishikesh Pai sir, Dr. Nandita Palshetkar, Dr. Mandakini Meg, ICOG chairperson, Dr. Sunita Tandurkar, chairperson, MSR, for blessing this today's program. Rishikesh sir also told about Chaitanya sir being the larger than life role, and we are seeing Nagpur being shining on a national background. So Chaitanya sir, thank you so much for being allowing us to be the co-convener for this program, myself and Rohan, and also allowing us to be the co-editors for this Change Souvenir. And I wish you all the best for a bigger role in the managing committee of MSR, which you are going for. I thank all the editors of Change Booklet, all the office bearers of AMOX, all the office bearers of MSR for bestowing the trust upon us for releasing this booklet and also for this program, for endorsing this program. I also thank all the speakers, experts, moderators, and panelists of today's program. And without taking much time, I also thank ICOG for allotting credit points for this program. I cannot thank more MQ Pharma, Rajiv Agarwal, Amit Borse, Kishore Moe for being there, for showing trust in us and helping us out to release this change booklet. Without taking much time, thank you one and all. Thank you all for participating.
1 minute, I would like to say something, that something is there in Maharashtra's water. Yeah, I see so many all of you are so much potential leaders. I don't know what is there in Maharashtra, which really makes such dynamic leadership. Anyway,
Water नहीं खून में है.
We are the best.
Because you are there, Nandita, Reshma, our leaders are there from Maharashtra, na? So we are.
Hey, Lakshmi, welcome. We are missing you.
Yeah, we are following your footsteps.
Lakshmi तैयार हो रही थी.
Yes.
Whenever I see Lakshmi, I remember her barfi.
Somebody
नीलेश दोपहर को 3 बजे पहुंच जाना.
Yes, madam. Yes, madam.
मैंने अमित की तरफ नहीं देखा, मैंने सिर्फ ऋषिकेश की तरफ देखा. That is what we are saying, कि our MSR leaders are so strong, and Nilesh, Chaitanya, we all are taking inspiration from you.
All these things, the moment started when I was actually there, and Mandakini Pariyar was there.
Yes, I really missed Rishikesh.
The state chapters, and she really said, Rishikesh, Sadhna Ben, I must acknowledge, was the president of ISAR, and she was very active, and she said, you must have the chair, and then that's how we started. All of us got together. Every time I think about Foxy or MSR, I always think about 1-2 dynamic people who left us, like Mandakini Pariyar, or at that point in time Praveen Patel was also a very dynamic individual. So some of them were very important and would have played a fantastic role in the development of the organizations, and they are no more with us. So we must always remember to remember them in our mind, and maybe I would request you to maybe institute something in our name by the society rather than by their family. What is the use of that? We should institute something in our name.
MSR can have something in her memory. I mean, I was going to say that.
Important. Yes. It is very important you took out Mandakini's name.
Yes.
Mandakini was the most instrumental in making a constitution of our MSR. And since Amit is there, this was a very good suggestion, Rishikesh. You, Nandita, we all are MSR people here. We'll definitely start something in a memory of Mandakini. Will definitely.
Good. You are a very generous man. Yeah.
Yes.
I love that aspect of you.
20th December, we are coming out with MSR one-day big conference where Amit is. Amit, let us have something on
Mandakini.
काय देऊ नको?
Christmasच्या दिवशी म्हटलं.
No. 20th December.
But we don't have anything to do on Christmas, so you can keep it there also. We have no problem.
But we'll definitely. Thank you for that suggestion and wish you all the best. We are late now.
I think we should let the program go ahead. Chaitanya, fantastic.
No, Chaitanya, we are already delaying you.
Thank you so much, sir, Nilesh sir.
Welcome, sir.
And thank you one and all. I now hand over the stage or this webinar session to Dr. Amit Borse, sir.
Amit, but I am not acknowledged, I think. Sorry, Amit. I think in between you had disappeared and all, because I was looking at, and there are so many other people also. They are all.
Amit Sunday के दिन भी काम कर रहा है.
Thank you, Dr. Kalpana ma'am. It is a pleasure. I am Dr. Amit Borse, Group Product Manager with IVA, a division of Emcure Pharmaceuticals Limited. Emcure is a pioneer in the field of gynecology and IVF, and it is an absolute pleasure to be here and get this opportunity. I like to thank all the chief guests and guest of honor for giving us this opportunity, and Chaitanya Shembekar for sir for conceptualizing this, again giving us an opportunity. As the release of the book Change marks a new beginning and importantly guidance for all infertility specialists across India, we at IVA, a division of Emcure, feels humbled to get your support for our academic initiatives during the COVID times. I'd also like to introduce my senior Mr. Samar Ghosh sir, Senior Director Marketing and Sales and Acute Cluster Head India Business. My senior Mr. Rajiv Agarwal sir, General Manager Sales and Marketing IVA, and my Director for Medical Services, Dr. Omkar Swami. I'll not take a lot of time, but I would like to share a video where we are announcing or showing our work during this 6 months of COVID. Give me a minute before I share this video. Please enjoy the video.
Good morning, all, madam. Yeah, good morning. Hello, doctors. He is joining. With season's greetings, I take immense pleasure and privilege to welcome you in our forthcoming new initiatives, IVA. That means it is actually made. Hello, doctors. With season's greetings, I take immense pleasure and privilege to.
I think we are not seeing any video.
Just give me a minute, ma'am. Just give me a minute.
I think right click करके play करो तुम.
Yes, ma'am. Yes, ma'am. Doing that.
Hello, doctors.
Is the video visible now?
No, the video is not visible.
Not visible.
You know
Amit.
what you have to do, Amit, is open the video on the background first, and then you share the screen.
Yes, ma'am. I'll do that. Give me a second.
Hello, doctors.
Amit, we are not getting the video.
Sir, give me some time. I will again work on it. We'll have to.
Maybe we'll start the session first, Amit, and then.
You can start the session.
In
sir.
between two sessions, we can.
Yes,
Yeah,
yes, sir. Please. Sorry.
Amit, are we ready with the poll?
Dr. Nilesh sir will take a quick poll now.
Sir, should I start the poll?
Yeah, so we have wonderful speakers here. We have Dr. Amit Patki sir, Dr. Madhuri Patil madam, and Dr. Rishikesh Pai sir to give wonderful talks on the new normal, about everything, about low AMH, about fertility preservation, and about PGTA. So we'll have this wonderful poll first to analyze about the trends in all the fertility specialists practice, and also the trends in the gynecologist's mind about these common topics today. So can we quickly have the poll, please, Amit?
This is the first question. Can you all see the question?
No, we are not able to see. Yes, now.
Yeah, now we are able to see.
Okay.
Should I end the poll, sir? Share the results?
Yeah. Please share the results. And I think at the end of the talk, Amit sir would definitely tell us the correct answer to this question, because he's going to talk on this topic. And these are the trends, sir, for you about the ovarian reserve testing. Second question about fertility preservation. Can we have?
Yes, sir.
Hello. Yes, sir.
How's everyone doing?
So in cancer patients,
can you see?
You can start IVF on which day? Is it day 2 of menses, GnRH agonist followed by stimulation, after pre-treatment with estrogen, or a random start protocol?
Should I end the poll?
Can we have 10 more seconds? And I think Madhuri madam is going to answer this question, which is in everyone's mind. Which is the best protocol to start fertility preservation in cancer patients? Yeah, we can end the poll now. So we have participants saying that 73% participants saying that random start protocol is the best. I think madam will answer this. And we have the last question for Pai sir's talk, the poll 3. So what is true regarding non-invasive PGTA testing as against the PGT testing? So non-invasive PGT testing for aneuploidy in spent medium may be more reliable than the trophoectoderm biopsy, or PGTA is better than NIPGT. NIPGT is still experimental, and blastocyst fluid is used for NIPGT. So which of the statement you find is the most correct one? And I think sir is now a pioneer of NIPGT in India. Yeah, I have heard he's talked about NIPGT. So I think he would comment about this poll in his talk once his talk is completed.
So should I end the poll?
Yeah, we can end this poll. 42% participants, 38% participants are saying that NIPGT is still experimental. I think the opinion will change once they hear sir. So yeah, thank you so much for the poll. And we can now start with the talks. Thank you so much.
Thank you so much, sir. We now move to our academic session, Academic Feast. So I invite Dr. Amit Patki, sir, for his talk on DOR and Advanced Maternal Age, the New Normal. To chair the session, I invite Dr. Vaidehi Marathe, Madam. Madam is the President of Nagpur Obstetrics and Gynecological Society.
I think I'm not able to see Patki sir over there. So some network issue with him.
स्क्रीन आपका है
इसको फुल करेंगे
वीडियो चलो
Patki sir ना
There you can start the session.
Should I start till the lockdown or should I wait? Dr. Chaitanya, should I wait or should I start introducing because I don't see him on the panel?
Whether you can start the session.
Can you hear me?
Yeah.
No, ma'am, we are not able to hear you.
Now we can hear you.
Can you hear me now?
Yes.
So should I start with his introduction because he's still not logged in?
Yeah, you start. We'll just check Amit's availability.
Can you just show Patki sir's previous slide?
This slide. Yes, ma'am. Next page. Yes, ma'am. Ma'am, can you see?
Can I start my sharing?
Yes, sir. Yes, sir.
Somebody else is sharing. Okay, go
on. It is Dr. Kalpana ma'am's screen. Kalpana ma'am, if you can stop sharing.
Yes, yes.
Just a moment, we are having Amit sir's introduction. Vaidehi madam is going to introduce Amit sir.
Yes, okay. Yes, sir.
I just
Go on.
Good morning, everybody. At the outset, I have to thank AMOG's President, Dr. Nandita Palshetkar ma'am, MSR President, and of course, my dear friend, Dr. Chaitanya, for making NOGS a part of this very prestigious program. Friends, before I begin introducing Dr. Amit Patki sir, I have to say a few words. Decorating the Christmas tree might be a family's favorite tradition, but the real meaning is to give back. We make a living by what we get, but we make a life by what we give. That is the joy of giving. And this festival is an opportunity to show our social commitment. And Chaitanya, our past president and my very dear friend, you have proved it once again that you are indeed the Santa Claus of Nagpur Obstetrics and Gynecological Society, consistently fulfilling the commitment to your social responsibility. Thank you for this very noble gesture. We value it so much. I assure you as the president that will use this contribution from you to a very noble cause. Coming to today's first session, I am so privileged and honored to introduce the first speaker of the session, Dr. Amit Patki sir. He's an all-rounder known for his oratory skills with rich content and excellent flavor of delivery, with most useful messages at the end of his talk. Along with his other credentials that he is currently the Medical Director of Fertility Associates Mumbai. He is the Honorary Associate Professor of KG Somaiya Medical College. He is the Consultant at Khar Hindujan Surya Hospitals Mumbai. He's been the Governing Council Member ICOG, Vice President ISAR, General Secretary MSR, Chair West Zone RCOG, and President MOGS in 2014 and 15. And he has 35 publications in national and international journals, 50 book chapters and has been the editor of 3 books and has 2 international patents in infertility, stem cell and stem cell research. And wow, he has been the TEDx speaker as well. But apart from that, what I strikingly remember about Dr. Amit sir is to his credit, his very innovative, captivating and scintillating, memorable Living Legends series. Maybe I wouldn't be wrong if I say it was more popular than the IPL today. And the complete show looked no lesser than a Karan Johar movie. Seriously, sir, I mean it. Presenting before you, the all-rounder, the multifaceted personality, a legend in making, Dr. Amit Patki, sir. I wasn't audible? Chaitanya?
Ma'am, you are audible. You just need to speak a little louder.
I've already finished. Do I need to do that again?
No, ma'am, you were audible.
I thought whatever I spoke was audible.
No, no, ma'am, you were audible.
Over to you, Patki, sir.
Amit sir, Patki sir.
Amit sir, kindly unmute yourself.
Okay. Can you all hear me?
Yes, sir.
Yes, sir.
Okay. So thank you very much. And at the onset, I would like to thank Nagpur OBGY Society, Dr. Chaitanya, AMOC Society, Dr. Nandita, and MSR for having me in this wonderful webinar on the new normal. Today, I'll be speaking on low AMH and poor ovarian reserve. Is there any hope? When you look at the histopathology of a newborn ovary, you would find that there is multiple primordial follicles. It is studded with primordial follicles in the ovarian cortex. And we know that before this girl attains adolescence, a large number of primordial follicles are lost. And this is a histopathological section of a young fertile woman where you will find that they are all spaced out. So you have lost a large amount of the oocytes even before they attain fertility. And this is the histopathology of an atrophic ovary where you find that the cortex has become very thin and there are multiple corpora albicans which are present within the medulla. So when you look at this graph, you will find that more than 50% of the oocytes are lost because of massive degeneration and less than 0.1% of the maximum oocyte population undergoes ovulation. So this is a theory of where a large number are lost even before we try to conceive with this woman. Now, what are the ovarian reserve testing that you could possibly do? And believe me, age is the biggest ovarian test. We know that the age, the ovary starts declining even as early 30s. And after the age of 37, there is a massive degeneration in the oocytes. The other biochemical markers are FSH, inhibin, on day 1, day
Dr. Kalpana ma'am, I think sir is there. Some problem?
Yeah, I think we are not able to hear him. Is there any network issue?
Yeah, he seems to have a network issue. We are not.
Amit, but I see him there in that participants list. Ma'am, because of network issue, he has again logged out.
Yeah, because I cannot see him. The screen sharing is also has been stopped.
So if we'll just call him up. Give us a minute.
Yeah.
We'll call Amit Patke, sir. Give me a minute.
Yeah, sure.
Patke sir has joined. I have made him a co-host. Dr. Patke sir, you can share your screen.
Sir is not visible, but I think sir has not joined yet.
Sir has again logged out because of internet connectivity. Should we first take the second session and then come back to Amit Patke sir, if you don't mind, sir?
Yes,
I think that is better.
Yeah, I think that is good. Vaidi ma'am, we'll call you later again. Ma'am, please be in touch with us. The second talk, the fertility preservation, the new normal. I invite Dr. Madhuri Patil madam for giving her talk, and to chair the session, I call upon Dr. Sneha Bhuyar ma'am.
Both of them are co-host. Just check your mic and
I'll just share the screen. 1 second for the CV. Dr. Sneha Bhuyar ma'am is the chairperson of the Study on Female Breast Committee FOXI for the year 2019 to 21, and she's the governing council member of ICOG 2021 to 23. I invite ma'am to kindly present the CV of Dr. Madhuri Patil ma'am.
Yeah, thanks Dr. Kalpana for the kind introduction. At the outset, I would like to thank Dr. Nandita Palsetkar, President AMOGS, Dr. Sunita Tandurwadkar, and especially our dear friend, Dr. Chaitanya Shembekar, for giving us this opportunity. Friends, as you all know, the COVID-19 has led to a great confusion and anxiety regarding the fertility treatments are concerned. There are SRM recommendations not to start any new treatment or investigations in regards to this. But if you are in the midst of the cycle, you can continue with the treatment, understanding the aftermaths of conceiving in the pandemic. Let us all listen to, but if at all the patient is diagnosed to have malignancy recently and there is an emergency for the treatment, of course, we have to go ahead with the fertility treatment. And let us listen to our today's speaker, Dr. Madhuri Patil, who is a clinical director of Patil's Fertility and Endoscopy Clinic, Bangalore, editor-in-chief, Journal of Human Reproductive Science, 2013 to 20, associate editor of the Oncofertility Journal, editorial board member, Endocrine Society Journal, 2021, founder chairperson of Karnataka chapter of Indian Society of ISAR, vice president of founder member of Fertility Preservation Society of India, vice president and founder member of the PCO Society of India, principal and course coordinator and examiner of the fellowship and certificate course in reproductive medicine, and member of International Reproductive Medicine Research Network, and our own Maharashtrachi Mulgi, Dr. Madhuri Patel. Madam, over to you.
Thank you for that introduction. And at the onset, I would like to thank Chaitanya, Dr. Nandita, and Dr. Sunita for inviting me here today to speak on fertility preservation, the new normal. So we know that today there is an increase in the incidence of cancer during the reproductive age, and majority of these young patients diagnosed with cancer will become long-term survivors due to improved survival and cure rates of cancer. Many of the survivors also will become infertile due to their treatment, and the ability to start a family and have a child is a key quality of life issue in cancer survival, and thus fertility preservation becomes very important. We know that radio and chemotherapy are gonadotoxic both in the males and the females, and the gonadotoxicity basically depends upon the age, the medication we use, and the dose of the drugs as well as the radiotherapy which is being given. And after treatment in the male, we could either have oligospermia or azoospermia, and in the female, the woman could have irregular menstrual cycle, premature ovarian failure, and infertility. And the methods used basically will depend upon the age, the type and dose of the adjuvant therapy that is going to be offered, the time available before chemotherapy or radiotherapy, and the length of delay to childbearing post-chemotherapy and radiotherapy. And it is recommended that the patient should undergo pregnancy only after 2 years after finishing her chemotherapy. All of us are aware that though the initial treatment plan is known, but the final treatment course is still not known. And therefore, there are certain issues that we need to address before we recommend fertility preservation. And one of them is the oncological prognosis and the quality of life, the fertility and the obstetric history and her obstetric potential, the availability and reliability of the fertility preservation technologies, the surgical modalities and expertise and cost and storage, fate of the gametes in the event of death, screening for all viral diseases, explaining the meaning of success, because we know, though we have stored her oocytes, the embryos or the ovarian tissue, but we cannot guarantee her a 100% pregnancy rate. We also need to look at the psychosocial perspective. The individual, parent and couple counseling is very, very important. And most important is obtaining an informed consent. So if you look at the effect of radio and chemotherapy on male fertility, there could be damage to the spermatogonial stem cells resulting in permanent azoospermia. And if there is damage to the differentiating germ cells, then what we have is transient azoospermia. And when there is damage to Sertoli cells, we can either have permanent or a transient azoospermia, and damage to the Leydig cells can result in testosterone deficiency. So then what do we do once we diagnose that the male is having cancer and is going to go for gonadotoxic treatment? But we need to understand that it is very difficult to evaluate germinal damage, because testosterone basically does not change because the Leydig cells are not affected. The secondary sexual characteristics are also unchanged, and therefore a semen analysis is required. And we know that at times the spermatogenesis can resume spontaneously even if fertility preservation is not done, and therefore post-treatment semen analysis is important, and the damage to the gonads is different in the pre and the post-pubertal males. So if you look at the fertility options in the male, and we know that this basically the spermatogenesis starts only in the pre-pubertal period, and therefore we can divide the fertility preservation into child and adolescents, where in the pubertal, we can still, as we know that we could still have some amount of spermatogenesis. We could do semen cryopreservation, and gonadal shielding is another option, but there are only case reports. And in the pre-pubertal period, gonadal shielding, where again we have only a few case reports, and testicular tissue cryopreservation can be done because that's the only option, though it is experimental. In the adults, we know that sperm cryopreservation is an established technique, but sperm cryopreservation with sperms obtained through TISA TSA, MESA, electroejaculation, and post-masturbation urine samples is still experimental for cancer patients, and there are very small case series which are being reported. Again, testicular tissue cryopreservation also can be done, but no reimplantations and pregnancies have happened in the humans, though there have been pregnancies in animals, and hormonal therapy, that is DNRH agonist, is not recommended in male fertility. At times, the patient comes to us after chemotherapy has been started, though we can obtain sperms and we can freeze them, but we have to explain to the patient that there's always an increased risk of aneuploidy, DNA damage, gene mutations, and though it has been found that the children conceived during chemotherapy may have not shown increased incidence of congenital anomalies, nor there has been an increased incidence of pregnancy wastage. The other effects of cryopreservation include ice crystallization with osmotic and chilling injuries, which can result in cytoplasmic fracture and effect on the cytoskeleton or the genome-related structures. Coming to testicular tissue freezing, we know that though it's technically feasible both in the pre and the post-pubertal males, but we must have the transplantation protocol as well as the storage protocol. And it has been seen that the reproductive efficiency and safety is still questionable for testicular tissue freezing because there have been no pregnancies as yet. And when it comes to autologous testicular transplant in humans, we also need to think about reintroduction of malignancy. The patient has to undergo surgery, there could be infection, and also there is increased incidence of epigenetic stability of germ cells damaged by cryopreservation and culture or transplantation. And as I've already said, that it has not yet been successful in humans, though it has been successful in animals. Coming to impact of radio and chemotherapy on the females, we know that on the ovaries, the chemotherapy can have direct ovarian toxicity. We look at what are the compounds which have increased incidence of toxicity. There could be vascular toxicity, and it can also affect the cytoskeleton, the DNA, as well as the oxidative stress in the ovary. And we know that radiotherapy, apart from its gonadotoxicity, it also can affect the uterine function. So here, if you look at the various chemotherapeutic agents, we know that severe damage is expected when any of the alkylating agents are used, and also when procarbazine and dacarbazine has been used. Whereas at times there could be damage with vinca alkaloids and antimetabolites and heavy metals, and again, but the incidence is much less than the alkylating agents. But whereas drugs which have low probability of ovarian damage include methotrexate, 5-fluorouracil, cis-mercaptopurin, vincristine, and mitomycin. And we do not really know the effects of these drugs like VM26, danirubicin, bleomycin, and doxorubicin. And in the fertility preservation in the woman basically is a personalized medical therapy, and one size fits all approach does not exist. And therefore, every woman, a multidisciplinary group of experts, should convene and analyze all the related issues prior to recommending the best option for the particular patient and spouse. And therefore, for this, identifying and selecting the female patient with cancer to whom we can offer fertility preservation depends upon a variety of factors, each with a significant as well as unique importance. And here, we need to look at the intrinsic factors like health of the patient now and after treatment, the age of the patient, and most important is assessment of the ovarian reserve, which is dependent on the clinical parameters, the menstrual cycle, the lab parameters like FSH and AMH, and ultrasound parameters like antral follicular count. There are also certain extrinsic factors which we need to look at, and that includes the nature of the predicted treatment, whether we are using high, medium, or low risk treatments, what are the practicalities present, the time that is there for fertility preservation, the expertise, as well as the funding, whether it is available or not. And most important thing to remember that resumption of menstruation post-chemotherapy does not mean that fertility has been preserved. And it's important that we assess these cancer patients during the oncofertility counseling for predicting the post-treatment ovarian function, predicting the efficiency of the different methods of fertility preservation that are available, and also optimizing the strategy of fertility preservation and balancing the benefits versus its side effects. And the main objective basically is to develop safe and efficient methods to preserve fertility, and the specific targets that include is to determine the ovarian reserve before and after treatment, to determine the effect of cancer on the ovarian function, and also to detect the metastasis in the frozen ovarian cortex. So this is a good diagram and algorithm which will tell us what we need to do when a patient comes to us who has a fertility risk. So first is patient assessment, wherein we know to know whether she's post or pre-pubertal. If she's pre-pubertal, we know that there's no other method except for ovarian biopsy that can be done. And here again, we know that we can also obtain immature oocytes during the ovarian biopsy, which are then subjected to IVM, and then oocytes are cryopreserved. And here the ovarian tissue cryopreservation is done. So in the post-pubertal, we have various options. We can do ovarian tissue cryopreservation, IVM, and ovarian stimulation also can be done if we have enough time. If the patient has a partner, we can go for embryo cryopreservation. And if she does not have a partner, we need to go for oocyte cryopreservation. There are other methods, like you can do an ovariopexy when the patient is going to be subjected to pelvic irradiation, and this will protect the ovaries. We can use GnRH agonist before and with chemotherapy to prevent the damage to the ovaries. And in patients who have early stage of cancer cervix, endometrium, and ovary, we can offer them fertility sparing surgeries. So when we're doing cancer surgery, as I said, fertility preserving surgery for both gonads and uterus can be attempted. And if not possible, we could do cryopreservation of oocytes, embryos, and ovarian tissue. When radiation is going to be offered, shielding is one of the options along with surgical ovarian transposition. And we can also cryopreserve the oocytes, embryos, and ovarian tissues. And when they're being subjected to cytotoxic therapy, it's best to cryopreserve the oocytes, embryos, as well as do ovarian tissue cryopreservation. And in patients who are going to be given tamoxifen or letrozole for a long time, especially in insulin estrogen sensitive tumors, then cryopreservation of the oocytes and embryos should be offered if the patient is more than 3 years, because we give the treatment for a minimum of 5 years. And when she would be 38, 39, probably we know that natural fertility decreases with age, and therefore that is essential. And if we are going to offer them a long-term adjuvant therapy with tamoxifen, then we need to do fertility preservation if the woman is more than 28 years. And according to the ASCO guidelines, we know that the established methods of fertility preservation is oocyte and embryo cryopreservation, which is routinely done in all IVF clinics. And but the most important requirement is the available time for hormonal stimulation, and we need to do a transvaginal ultrasound with transvaginal oocyte retrieval. Oocyte cryopreservation should be performed only in those centers who have adequate experience, and embryo cryopreservation, as all IVF clinics are done, can be done in all clinics. And as we said, that random start ovarian stimulation protocol is now possible. And these are the various protocols that what we can use in fertility preservation. One is the conventional protocol. The other is a random start protocol, where we can start in the late follicular phase. We can do a luteal phase halt, or we can start in the luteal phase itself. And special consideration should be given in patients who are hormone sensitive, wherein we need to use letrozole during stimulation and post oocyte retrieval. And the other option is double stimulation, so that we can obtain more number of oocyte and embryos. And to enhance the cumulative live birth rate per oocyte retrieval, we need to have efficient cryopreservation programs for oocytes and embryos. And we know that today vitrification is the best technique and is the technique of choice for cryopreservation. Coming to immature oocyte retrieval, freezing of in vitro mature oocytes, which can be obtained either by transvaginal ultrasound guidance or from a oophorectomized or ovarian during after ovarian biopsy. And we know that it is still experimental for fertility preservation. And we can see that when we dissect the ovarian tissue for cryopreservation, and if you look at the culture media in this dish, we can see plenty of these immature oocytes, which can then be matured in vitro and frozen. And this latest paper in 2009 said that healthy live birth rates can be achieved from IVM oocytes and vitrification, even when no live births have been reported in cancer patients, but they have been reported in the non-cancer patients. And the efficiency of IVM is still low and requires further improvement in the IVM and also the cryotechnology. The number of M2 oocytes obtained is significantly lower with IVM, and it is about 58%. And the number of oocytes and embryos cryopreserved is significantly lower as compared to mature oocytes. And therefore, we require an improved understanding of the mechanisms which are related to IVM. Coming to ovarian cortex cryopreservation and orthotopic Plansan, it is no longer considered as an experimental method, and this has been published in December 2019. And it is indicated when immediate therapy is required, and it is the only option in prepubertal girls. And once the cancer is cured, we can transplant back the ovarian cortical tissue back into the woman. And it allows to preserve steroidogenic as well as reproductive function, and it can be performed at any time of the menstrual cycle and allows to retrieve a high number of primordial follicles. And also we could we could collect immature oocytes and mature them and use them. So it's important that the age has to be less than 35 years, but if the age is good, we can do it even at a later age. Basically, we have to know that the patient has a good chance of 5 years survival, and it has to be done before the chemotherapy has been initiated. And most important to know whether there are chances of metastasis of the tumor in the ovaries or not. And we also need to know that the patient is fit for anesthesia, and the informed consent is very, very important. The advantage is that we can reinstitute not only the fertility, but also the endocrine and the exocrine ovarian function. And it, as we have already mentioned, that it can be done in emergency and basically does not require any transvaginal scans, and we can combine it. But the drawback is that we know that it is a surgical procedure, and we are not very sure of the success rate, though now we've got several pregnancies, but there is always a risk of malignant cell reintroduction into the patient, and even follicular loss has been seen after grafting. And the results basically with slow and vitrification depend upon the proportion of the intact primordial follicles, the primordial follicular density, proportion of normal stromal cells, as well as the DNA fragmentation in the primordial follicles. And this meta-analysis published in 2017, which included 14 studies, compared slow freezing versus vitrification. And when they look at the primary endpoints, which was intact primordial follicles, they found that there was no difference. The DNA fragmentation was less with vitrification. And at the secondary endpoints, which was the number of stromal cells, which were again higher with vitrification, and the primordial follicular density, they found that there was no difference. And it was seen that once it's been transplanted back, 78% of the patient had a normal restoration of the ovarian function, and you can see that the FSH values came down, and the number of live births also have increased, and today we have a live birth rate of almost 65%. And almost though there were more than 200 pregnancies, there have been 130 live births worldwide, and almost 50% of the pregnancies were achieved spontaneously, and only a small percentage, that is 40%, required an IVF. And most of these babies are born after slow freezing. There are very few or handful of babies born after vitrification. And most of the European countries and the US, they are performing slow freezing. It's only the Japanese which have started with vitrification, and they have reported few pregnancies. And if you look at several papers that have been published on ovarian tissue transplantation, live births have been reported both from prepubertal as well as postpubertal ovarian tissue transplantation. And in the prepubertal ones, it has been seen that they could achieve the menstrual cycle. And this one was in patient of Ewing sarcoma, and the other one was for sickle cell anemia. Therefore, before fertility preservation, it is important to know the ovarian involvement, as I told you, because we have to look at the safety options and we need to know what is the risk of metastasis. And this algorithm gives us the risk of metastasis, and the highest risk is seen with neuroblastomas, leukemias, Burkitt lymphomas, and fallopian tube cancer, whereas low risk is seen with Wilms tumor, Ewing's sarcoma, breast cancer stage 1 to 3, non-Hodgkin's and Hodgkin's lymphoma, rhabdomyosarcomas, osteogenic sarcomas, squamous cell carcinomas of the cervix, and endometrial type of endometrial cancer. And moderate risk is seen with adenocarcinoma and adenosquamous carcinoma of the cervix, colon cancer, and breast cancer stage 4. So it's very important to know what type of cancer it is. And depending on that, then we can decide the method of preservation. So if there is a high ovarian involvement risk, we can basically do ovarian tissue cryopreservation with IVM. That's the best option. But we cannot do an autograft, but we need to do a xenograft. But if there is low risk, we can either do transposition of the ovaries, and if chemotherapy can be delayed, we can perform ovarian stimulation and do oocyte or embryo freezing. But if we cannot delay, then basically ovarian cryopreservation is the best option. GnRH analogs also protect the ovary, and it's more so we will see in which cancers it should be used. And basically its action is by decreasing the utero-ovarian perfusion and thus decreasing the exposure of the ovaries to chemotherapy. And it directly also acts on the ovaries, having an anti-apoptotic ovarian effect. And it mimics a pre-puberty stage wherein you have a low FSH levels, and therefore there are decrease in the growing follicles. And therefore it should be considered as a reliable strategy when chemotherapy has to be initiated. And this paper in 2019 said that the data is quite conflicting on the use of GnRH agonist, and we need to rely on surrogate markers such as assumption of menses or hormonal levels, which may not be the best endpoint in many studies. And therefore they concluded that it should be used in situations where proven methods cannot be used, and we should not use them in all patients. And this paper looked at, and they said that the safety and efficacy is best seen in a woman with breast cancer, and there was no impact when we used GnRH agonist on the disease-free interval and had no significant trends towards better overall survival. But it did protect the fertility. But in other malignancies, they said that the protection is there, but no pregnancies have been reported as they've been reported in women with breast cancer. And they also said that the GnRH agonist administration was associated with significantly reduced risk of chemotherapy-induced premature ovarian insufficiency, and the pregnancy rates in lymphoma reported were 57% as against 42%, but in hematological malignancies, they were as low and almost similar whether you use or you do not use the GnRH agonist. Oophoropexy is another option for protection against pelvic irradiation, and basically you need to move out the ovaries from the pelvic gutter, but close to the time of radiation, but still they could be affected because of spontaneous ovarian relocation, scattering irradiation, as well as they could be decrease in the blood supply. And it is reported by Toga Stulandi in 2018 that overall protection with oophoropexy is about 88%. And it's important that at the time of transposition, one can also have an option of cryopreserving the ovarian tissue. So looking at the various fertility sparing surgeries that can be offered for cervical cancer, stage 1A1, A2, stage 1B to A, after doing the sentinel node biopsy, we can offer conization, simple trachelectomy or radical trachelectomy. In endometrial cancer type 1, stage 1, grade 1, we can offer them medical treatment with progesterone. And in ovarian, bilateral ovarian borderline cancers, especially stage 1A, grade 1A, and grade 2, germ cell tumors, grade 1, we can offer them unilateral or bilateral cystectomy, or we can preserve one ovary and remove the other ovary. In vulval and vaginal cancers, basically we can do wide excision of early vulval cancers, and fallopian tube cancer, fertility preservation should not be offered. In children, because there's a problem because of limited sexual immaturity, and it's basically experimental, and it includes testicular and ovarian cryopreservation. Fertility preservation is also used for non-oncological female patients when they are exposed to gonadotoxic agents in hematological disorders like sickle cell anemia, thalassemia, aplastic anemia, autoimmune disease like SLE, multiple sclerosis, autoimmune thrombocytopenias, and rheumatoid arthritis. When there is a surgical menopause, especially when prophylactic oophorectomy is done in patients who are BRCA1 and BRCA2 mutation carriers, or for benign ovarian disease, especially severe endometriosis. It also can be offered wherein there is a chance of premature ovarian failure, like you have chromosomal and genetic abnormalities like Turner syndrome, trisomy X and Fragile X syndrome, as well as autoimmune diseases, which can result in premature ovarian failure. And we also can offer women who wish to postpone their motherhood, and that's called as social freezing. And in transgender man, wherein it should be done before initiating hormonal and correctable therapy. I just gave a lecture. I just gave a presentation about 2 weeks back in a conference which spoke only about transgender, and I spoke on fertility preservation, and I was very happy on what work that association is doing. So when we talk about fertility preservation for transgender men, it is very easy because we can cryopreserve the sperms, and then we can use either a donor or a partner oocyte, and you can use surrogacy, or you can transfer it into the partner. But in a transgender man, that is a woman becoming a man, it is very difficult because this patient has to undergo controlled ovarian stimulation, transvaginal scans, oocyte retrieval, oocyte or embryo freezing, and ovarian tissue cryopreservation. And we could use either partner or donor sperm with a surrogate mother or self uterus. But there are certain legal aspects to it, and certain European countries, they do allow, certain they do not allow. In India, gender change is not governed by law, and therefore there's no need to do sterilization, and hence we could offer them fertility preservation. So though we can offer them IVF, ICSI or IUI, but surrogacy cannot be offered because it is not allowed in transgender patients in India. There are other neotherapies like use of stem cells, where we could create artificial gametes from stem cells. We could use them for regeneration of the reproductive organs, and uterine transplant can also be done, especially wherein you have an absolute uterine factor, and mostly it is done for patients who have Mayer-Rokitansky-Kushner-Hauser syndrome. So totally there have been 52 uterine transplants that have been done all over the world, and 73 of them have been successful. 23 have experienced complications and required hysterectomy, and 3.8, the procedure was not done because they had complications during surgery, and about 19 children have been born in total after uterine transplant. And therefore, when we offer fertility preservation, we need to look at both the safety as for both the mother and the child, and therefore no detectable increased risk of disease recurrence with most fertility preservation methods, and pregnancy, even in hormonally sensitive tumors, has been seen. Cancer treatment has mutagenic effect on the oocytes present in the growing follicles, and the risk is related to the stage of the oocyte development during exposure to the drugs, and therefore it's best to use the oocytes or the embryos which are cryopreserved before chemotherapy. The cancer therapy of fertility preservation does not increase the risk of cancer, the chromosomal abnormalities, congenital abnormalities, or the fetal malformations in the offspring if conception happens 1 year after cessation of the treatment. But it's most important for us to remember that it has to be an interdisciplinary team approach where the oncologist, the reproductive, and the counselor should form an important part of this team. So I will summarize by saying that assessment of risk for infertility is important in all patients requiring fertility preservation, which should be communicated to the patient, and counseling should be done. And patients at risk for treatment-induced infertility and who are interested should be referred to the reproductive specialist. And then we need to assess the ovarian reserve. And then we need to, or if they are eligible, we could offer the various techniques which are discussed. And I would like to conclude by saying that awareness and demand for fertility preservation has grown both for oncological as well as non-oncological cases in situations in which treatment threatens fertility potential. It is also used in those women who wish to defer reproduction. Clinicians should be aware of the infertility risk related to gonadotoxic treatment as well as severe non-oncological diseases. the pathology itself and or the treatment can have a negative impact on their ovarian reserve. Ovarian transposition and GnRH agonists, though experimental, minimize the effect of cancer therapy on fertility potential, but necessitate further confirmatory studies. Fertility counseling and access to fertility preservation should be provided before starting any gonadotoxic treatment or before any ovarian damage is induced by the disease itself. I thank you all for a patient hearing.
Thank you so much, Dr. Madhuri, for that wonderful, elaborate talk. My question to you is, what are the practices at present as far as this COVID era is concerned regarding the fertility preservation?
No, I think we are doing IVF, so we can offer everything. We can offer semen cryopreservation, we can offer oocyte as well as embryo cryopreservation, as well as ovarian tissue cryopreservation.
Okay, any comment on the ASRM recommendations?
Yeah, that's what the now I think in European countries, they have restarted doing all the IVF procedures. And even in USA, they have started, because I know many of them. Yesterday, we had a meeting and they said that all of them have restarted their work. So I don't think, but we need to take the due precautions during the COVID, wherein we need to test them before they start the treatment, before the oocyte retrieval, and before the embryo transfer. So I think if we take due precautions, we can probably do all the procedures, because now the treatment has been initiated in most of the countries.
Okay, thank you so much. Any, do we want to take the questions now?
Yeah, there is. Yes, there is a question from Dr. Darshana Pawar. So Dr. Darshana Pawar from Nagpur says that how does one manage egg pickup in a virgin for social egg freezing?
Yeah, so basically we have to explain to them, counsel to them, and then basically we require to do a transvaginal scan. So first time the patient is surely going to have pain, and then once you start doing a transvaginal scans, I don't think it is going to be difficult in doing a transvaginal aspiration. And we have been doing it in many of the patients who want to postpone their pregnancy. And they're ready for it because they have come for it. Because we cannot do a transabdominal aspiration, or a transabdominal scan does not give us the correct information about the follicular size also. And therefore, then it's a waste of time and money for the patient, because if we don't give the trigger at the right moment.
Thank you, Sneha ma'am and Madhuri madam. We next move on to the next talk. I invite Dr. Lakshmi Shikhande ma'am to please share this.
Ma'am, can I take a minute if you really don't mind, please? Can I take a minute?
Yes, Amit.
Please. Thank you, ma'am.
Okay,
sir. Dear doctors, sorry for the technical glitch we had in between, but I would like to showcase the work we have done during our COVID period, and would like to present this video to all of you. Can you see the screen?
Hello, doctors. With season's greetings, I take immense pleasure and privilege to welcome you in our forthcoming new initiatives, IVA. That means IVF Virtual Academy. It is actually made for you and for your networking, to make it more stronger as a knowledge partner. To make things sustainable, we will be requiring your continuous help. Emcure has been always in the frontier to offer innovative solutions in healthcare through its quality medicines and quality and scientific services. Our aim is to remain trusted and preferred partner of yours, so that we can serve millions better than before. IVA is one of the such fantastic initiatives which has been conceptualized, which has been designed, and after that it's going to be launched by our medical marketing team. And needless to mention that without your continuous and incredible support and encouragement, this would have not been made possible. Thank you once again for helping such kind of initiatives to come into reality. Thank you so much. Good day.
Good morning, dear doctors At the onset, let me wish you and your family a very happy and prosperous Diwali. In view of current situation when everything was at a standstill, AIVA and IVF division of MCure has emerged as a strong academic partner to proliferate the science. AIVA collaborated with regional and national societies and international speakers to conduct more than 125 plus webinars, Materna School of ART and Pro Zindagi webinars. With 550 plus experts and 280 plus topics we have covered, we thank you all the doctors and societies for their incredible support. Thank you very much for your support. Thank you.
Good morning, friends. Recently, we have noticed how the world is volatile, uncertain, complex, and ambiguous. And there was a vigor for digital transformation. MCure, being a most innovative and trusted healthcare partner, took a positive step to bring all the experts in the field of infertility on one platform to discuss the recent trends and development during the difficult times of pandemic. This initiative is only successful because of keen interest of practicing infertility specialists in the country and even experts from overseas. I, on the behalf of AIVA and IVF division of MCure, take an opportunity to thank all the faculty and delegates who kept us motivated and supported for this more than 125 webinar under the theme of Programming 28. Thank you very much.
Rajiv sir, may I ask you to have a word, please?
Yeah, thank you, Dr. Amit. First of all, I am very, very proud and privileged on behalf of MCure to share this platform with the glittering stalwarts and with the sharing the platform with AMOX, MSR, and Nagpur Obs and Gynec Society. I would like to thank Dr. Chaitanya Sambekar sir for initiating this wonderful initiative. And our objective is same, academics, and that is the reason we have started one webinar in April, and आप लोग का साथ मिलता गया and कारवा बन गया और ये चलता रहेगा. And MCure is always a preferred partner and will always there to support the academics. Thank you very much for giving us the time. Thank you, Rishikesh Pai sir, Nandita madam, Sunita madam, Amit Patki sir, Jaydeep sir is there, Madhuri Patil madam is there, Lakshmi Srikhande madam is there. Thank you very much. If I miss somebody, I thanks all and everybody. Thank you very much.
Thank you, Kalpana ma'am. All over to you again.
Yeah. Thank you, MCure, Dr. Amit Borse sir and Rajiv sir. I now request Lakshmi Srikhande madam to please chair the session on PGTA by Dr. Rishikesh Pai sir. I'll share the screen, ma'am. Srikhande madam needs no introduction. She is the medical director of Srikhande Fertility Clinic, chairperson designate ICOG 2009. She has received many national and international awards. Ma'am, please kindly introduce Rishikesh Pai sir.
Yeah, please display his
Yeah.
CV slide.
Yes.
Friends, very good morning to one and all. It's always a pleasure to introduce my dear friend, Dr. Rishikesh Pai. His passion for latest technology is commendable. Since last so many years, I am hearing him on latest technology. Whenever any technology comes in IVF, in any part of the world, he will go there, he will learn that technique, he will bring that technique to India, and he doesn't keep it to himself. He will disseminate that knowledge to all his fellow colleagues through parts of CMEs and now through webinars. So hats off to you, Rishikesh, for that passion. To formally introduce you, he is the president-elect of FOXI. He was Secretary General FOXI and he has held many positions in FOXI, but basically he is very passionate about his work, that is IVF, and he is director of, I think, almost 9 IVF chains. He is the director of Bloom Chain, and he is member of board of directors of the World Body of Infertility. So good, Rishikesh. He is representing India in endoscopy field also and in infertility also. He has received many national and international awards and is a fantastic orator. So I invite you, Rishikesh, to speak on yet another technology. I know you are very passionate about this. Floor is yours, Rishikesh.
Yeah. Thank you. Can you hear me?
Yes, you are
So
audible.
I will, just request some time. Little. I had calculated 30 minutes, but I try to finish it in 20 minutes. So without much ado, I would like to say that historically, if you see the genetics, the main breakthrough came in around 1953 when Watson, Crick, Wilkins, and Franklin published 3 landmark papers in Nature on 25th of April. And this gave them the Nobel Prize in 1962. It was how they established the double helix structure of the DNA. And after there was a rapid growth in the knowledge in DNA. In 1980, Sanger got the Nobel Prize in chemistry for what is known as Sanger's sequencing now. And around 83, PCR was discovered by Carey Mullis. He received the Nobel Prize in chemistry for that in 1993. And then there was a lot of development in diagnostics. Originally, there was only karyotyping, but after the karyotyping came FISH, which was Marie-Lou Purdue and Gall. And that FISH developed over many years. From 1969 to 1990, FISH developed. In 1997, ARES-CGH was introduced by Salinas Toledo. And in 2000, Nick McCook's group, which was the pioneering team at Solexa. Solexa was later bought over by Illumina, and they were the ones who invented next-gen sequencing. In 2013, actually, genome editing was introduced by Charpentier and Doudna, and around 2013 was the time when NGS was introduced in pre-implantation genetic testing as well. Then if you look at the genetics of reproductive medicine, you have prenatal and pre-implantation genetics falls under PCP&D Act in India. We can do genetic analysis of embryo so long as we do not disclose sex of the embryo, which is punishable. Then we have male infertility, genetics of endometrium, genetics of recurrent abortion, genetic testing, DNA fingerprinting is there, carrier screening, expanded carrier screening, cancer screening, gene therapeutics is there. DNA, recombinant DNA technology can be used to produce a lot of medicine. Gene therapy has come back in a big way. And the final frontier is gene editing as well. If you look at the embryos, I want you to look at this slide. So what is a euploid embryo? So this is the inner cell mass and this is the trophectoderm. The child is born from the inner cell mass and the trophectoderm gives rise to the placenta. So if the red color cells are less than 30%, it is known as a normal euploid embryo. If the red color cells are between 30 to 50%, red color cells are the abnormal cells and they may be either in the inner cell mass or in the trophectoderm. This is called a mosaic embryo, low mosaic. If it is between 50 to 70%, it is known as a high mosaic embryo. And if the aneuploidy cells are more than 70% of the entire embryo, we tag the embryo as aneuploid, and that is an abnormal embryo. So this is how. So how does aneuploidy form in embryos? There are two contributions to aneuploidy formation. One is a meiotic contribution and one is a mitotic. Meiotic is at the time of fertilization, you may have an abnormal sperm or an abnormal oocyte, and that's more dependent on the man or the woman's, how their age, whether they are on supplements, antioxidants, stimulation protocols, etiology of the infertility, both in men and women. So if you look at this meiotics, this is a normal sperm and an abnormal oocyte, while this is a abnormal sperm and a normal oocyte. Both of this will give rise to an abnormal embryo. Once it starts proliferating, these are all abnormal cells, but somewhere down the line, again, non-disjunction occurs, and some degree of normal cells starts forming. And so there is a combination of white cells that are normal and black cells that are aneuploid. And based on I told you the proportion of the normal and the abnormal, you classify them into euploid embryos, low mosaic, high mosaic, and mosaic embryos. So the next step after normal fertilization, also there can be abnormal embryos. That is known as mitotic contribution to aneuploidy. And this is what happens, that the sperm and oocyte normally fertilize, and as they are dividing, somewhere down the line, the non-disjunction starts, and the two cell lines again form one abnormal cell line and one normal cell line. And in this non-disjunction is based on the lab parameters. So you must have a very good lab. If you want to create a blastocyst, if you have a bad lab, your incidence of aneuploidy will be very high, because those lab parameters will influence the embryo. So that is why if you have not a great lab, you should do day 3 transfers. If you only have a good lab, you should do a day 5 transfer. So it depends on a lot of things like quality of the lab, skill of the embryologist, culture media, air handling system, pH stabilization, everything that is, I can't go through all these slides. I'll just jump to them. But now when you do the analysis, when you are doing the biopsy, that contribution, how you do the biopsy, how you collect the sample, even all that will influence the aneuploidy analysis and outcome. How you give it to the genetic lab, what is the kind of machine you use, what is the kind of artificial intelligence you use to interpret the findings, all that will contribute to the ultimate diagnosis of whether that embryo is an aneuploidic or euploid embryo, and whether there is a mosaicism, and if there is a mosaicism, whether it's a low or high. This is a beautiful paper in 2007 by Katz Jaff. And what she did was she analyzed all the lab practices. So she took one IVF group, and they had 6 centers, and she analyzed those. The group was so standardized that all the centers had the same degree of aneuploidy incidence. When there was the mosaicism incidence was within 3%. Just look at the standardization that the group had as in terms of practices in their lab. Now, coming to pre-implantation genetic testing, it is known as PGT nowadays. On the original, it was called PGS or PGT. And you have the pre-implantation genetic testing for monogenic disorder like thalassemia, sickle cell anemia, which is the commonest, cystic fibrosis in Ashkenazi Jews and all that, congenital absence of Arch difference, you have cystic fibrosis. So all these in India, we have thalassemia, and sickle cell anemia is there a lot prevalent in Africa. So if you do testing of the embryos to find out a single gene disorder defect, it is known as PGT-M. PGT is pre-implantation genetic testing for monogenic disorders. If it is for, sometimes there is a structural rearrangement of chromosomes, especially in patients who are having recurrent abortions, and you do their karyotyping and there is a structural rearrangement, then you do analysis of the embryos. So that is known as PGT-SR. SR stands for structural rearrangement. And then we have the PGT for aneuploidy screening, where you know that the embryo may be having a trisomy 18, 19, 21, depending on the age and the aneuploidy incidence. So it's called PGT-A. And the new exciting thing that is coming up now is PGT for polygenic disorders, which is called PGT-P. So now in the future, if you have diabetes, hypertension, cardiac disease, and there are multigenic contributions of multiple genes to this. It's not like a single monogenic disorder. So you can predict, you can create a prediction model, and based on that, if you can analyze the embryo and tell, okay, this embryo will land up with diabetes type 1 or type 2. So this is a very exciting field. In the future, it's going to open a new vista of medicine for us. So if you look at the PGT-M, there are a lot of indications, like for structural chromosomal anomalies, you can do it. You can do it for single gene disorders. There are nearly 10,000 single gene disorders at present. Commonest are cystic fibrosis, beta thal, sickle, myotonic dystrophy, Fragile X syndrome, DMD, hemophilia. Then you can do it for mitochondrial disorders. You can use it for deselecting genes predisposing to hereditary cancers. This is becoming a big thing again. The selecting histocompatibility sibling. So you have a first child which is affected. So second child, you do a PGT, match it with the first child and do an HLA matching, and then when the second child is born, you can take the bone marrow of the second child and treat the first child. Initially, it was done only for blood disorders like thalassemia, but now the big thing is to do it for childhood cancer. So you have a child who is having a cancer in childhood and she needs a bone marrow or he needs a bone marrow, you can have a second sibling and match it with the HLA and treat it. So it's a big thing. And of course, you can do expanded carrier screening. So now in our lab, for example, we have a expanded carrier screening test where we can screen for 3,000 genes. So, you know, if a couple comes to us and in the original time, premarital counseling, they used to do only for thalassemia. But now we can do the couple screen for about 40,000 rupees. We can do for both of them and cover all the 3,000 genes. And if there is a recessive gene that is picked up, we can offer them either a pre-implantation genetic testing for a single gene disorder with that particular gene that we have picked up, or we can offer them a pre-implantation prenatal testing, you know, because PGTA, not everyone can afford. So we have already in our labs, we have done a lot of work in pre-implantation genetic testing for monogenic disorders. Already many thalassemia babies, sickle cell babies have been born. Now recently we have done a neurofibromatosis patient as well. So that is as far as PGTM is concerned. Now let's come to PGTA. So I told you that is as far as single gene disorders are concerned. Now we want to have, what is PGTA? That many of these embryos that you see morphologically, they are normal, but actually genetically they are abnormal. So when you put them into the, do transfer with them, they either don't implant or they have a miscarriage, which is higher or incidence, or sometimes they may go to term and what is known as viable trisomy. It can, you can deliver a trisomy child, you know, if you put these embryos in. So, you know, there's a, so what are the indications of PGTA? One is advanced maternal age. In many centers, you have to have your own definition. Some of them have an advanced maternal age of 35, or someone may be having 37. As far as the PNDT Act is concerned, advanced maternal age is 35. So in our group, we classify indication more than 35, we can do a PGTA. Then patient with recurrent implantation failure, patient with recurrent miscarriages, especially high order recurrent miscarriages, more than 4 or 5. The other day, I had a patient with 7 miscarriages. I did IVF and I had 9 blastocysts. Imagine, because they're all fertile. The recurrent miscarriage patients are all fertile. So the blastocyst formation rate is very high. So then we did PGT analysis, and then now we will transfer the embryos after 1-2 months when the final report comes. Then you can also use it for reducing the time taken to. So many people are, many couples now in US, in China, many cases, they say, doctor, we want to do, or it's called on-demand PGTA. They say, no, we don't want to go and do transfer. You do the first IVF, get the best embryo, do the testing, and put the normal embryo back. Why should we do it? So there is a lot of people, nearly 20% of American patients are going for what is known as on-demand PGTA. And in fact, in China, this on-demand PGTA is huge now. I've come to know that, like, one of my friends has got 5 sequencers. Imagine having 5 sequencing machines in her unit. She does about 20,000 cycles a year. And so almost everyone who does, so they don't wait for a recurrent abortion or recurrent failure. They'll say, no, we want it right at the beginning. So we are also, you can use it for research and analysis of new lab techniques. So we are going in for spindle transfer. We go in for freezing, freeze-all. So you can actually freezing of oocytes, donor oocytes. So all these embryos that are created, they can have problems in their embryos. They can have aneuploidy, they can have imprinting disorders. So you can use pre-implantation genetic testing to find out whether these new techniques that you are using can cause imprinting disorders or not, or cause genetic abnormalities or can cause off-target mutations or not. If you look at the PGT, the screening is done by the biopsy is done. It can be either a day 3 biopsy, which is called a blastomere biopsy, or a day 5 biopsy. This is an inner cell mass, and this is a trophectoderm. So a day 5 biopsy is known as a trophectoderm biopsy. So what is the, how then once you take the 4 to 5 cells, more than 5 you take, you will damage the embryo. Less than 4 you take, you don't have enough DNA for amplification. So you have to be very intelligent in the biopsy. It's very important. If you do a wrong biopsy, in fact, it can increase your aneuploidy in the cells which you are biopsying, and that can give a wrong result to you. So how you can use a standard RT-PCR, especially when you are doing thalassemia patient and all these PGTM, you know, because the NGS, if you do on a thalassemia patient for diagnosis of a single gene defect, it is very costly, but it's more accurate. But you know, you don't have that much money, you can still do the traditional RT-PCR and you know, multiplex PCR along with the Sanger sequencing and get a report of the biopsy. But for aneuploidy screening, you can do fluorescent in situ hybridization. So this was the original technique where you can see here, it is a fluorescent dye. So orange is 21 chromosome, orange fluorescent dye. There are 3 spots of 21. So you know that it is a trisomy 21. But the problem with this is that you can't trace all the chromosomes, and there's a lot of result interpretation. So it's still a fantastic technique for a rapid diagnosis or a confirmatory diagnosis, but it is not a good technique for overall diagnosis, and because of the problem of the number of chromosomes it can screen. So in 2012, the new technology came in of what is known as comparative genomic hybridization. So it was an advance to the technique of FISH only, but it had there was a lot of, these are slides, and there are a lot of bits of chromosome that are embedded on this slide, and then you have the same fluorescent technology which you use, and based on that, almost all the 24 chromosomes could be analyzed. But it was very quick. Can do the test in 4 to 6 hours, and many of the people, last 20 years, most of the work has been on what is known as CGH microRNA technology, and it is cheap, easy, fast, and there's a low failure rate. So there are certain things it cannot test for aneuploidy, duplication, deletion, and mosaicism accuracy is not as good as a NGS technology. So in 2013, the NGS, so first came the FISH technology, then came the CGH micro technology, and Nathan Treff is a damn good guy. I heard his lecture recently on polygenic disorders and how they are going to screen them using biobanks in UK. And he is the one who introduced NGS for analysis of the. So before that, CGH micro was used. Then Nathaniel Treff, along with that same time, Zhang also you introduced it, and Zihong made a comparison of the two studies. So what exactly is NGS? So this is a beautiful. I picked up this from Alan Handyside. Alan Handyside is the father of PGD. 1989, the first baby hemophilia. He was born in United Kingdom and in the Alan Handyside lab, along with RML Winston from Hammersmith. And this is what he explained. So what you do is that in an NGS, you basically do the biopsy, then you lyse the DNA, then you amplify it. The DNA is very small. So you have to, how can you do an analysis? So you have to amplify it using a RT-PCR or PCR technology. After that, you have to tag it. See, what happens is the NGS does all analysis of all the embryos in the one tube. So, because normally NGS takes 3 hours for amplification, 3 hours for template formation, and 3 hours for sequencing. So, totally 9. How can you keep on doing one embryo at a time? So, you have to put all the embryos in the same tube. You can put 90 embryos in the same tube and sequence them at the same time. How can you do that? How will you mix the DNA? How will you know which is whose DNA? So, you have to tag the DNA. So, this is done by a barcode. So, there are adapters and barcodes that are so you tag each of the embryo, and this is called library preparation. So you tag the embryos and then put them in one tube, and then you amplify them. Then the machine reads the sequence, and the sequence is read. And at the end of the reading, all the DNA, small snippets of one embryo, because of the tagging, are clubbed together, and the final reading is done, and final sequence is given out. So this is how you do the NGS. So you do the whole genome amplification using PCR technology. You do the fragment library construction. After that, you do the amplification, and you do then with using a template, and then you do this sequencing in this machine. So this is how we do it. So if you look at this embryo, for example, this is after the NGS, you can see here the chromosome number 22. This is the first chromosome 22. The second chromosome 22 is here, and sitting on top is the third chromosome 22. So this is how you can diagnose the trisomies, and this is another way of diagnosing the same trisomies. So if you look at it, normally there are 2 chromosomes. So if you see in the graph here, 2 is a baseline. So all the chromosomes are aligned on the baseline. So this is a euploid embryo. All chromosomes are at 2 level. Then look at this aneuploid embryo. This is a 45 minus 18. So 1 chromosome is missing. So you look at the 18 number chromosome is not there only. It is missing. So this is a aneuploid 45. So this is how you diagnose the embryos, and this is how you do the analysis. I've already told you how you do the analysis. So basically, you can see here how we do it. So we do the biopsy here. You can take 3-4 cells of trophectoderm. You cut them with the laser. You can see you're cutting them with the laser. You can even take the fluid from around the embryo. This is what we do in the non-invasive PGS. So we take the fluid from the embryo. And then we take this and we have to tube it, because we have to wait for embryos. We can't do one embryo at a time. You have to freeze them. So after tubing the embryo, you freeze them and store them at -20 degrees centigrade. So it's very important to have a -20-degree freezer. We have in our lab, we call them, our lab is called Bauficki Genetics. And in this, we store the samples in -20 degrees centigrade till we have enough samples. Normally, it's 92 samples we can't wait for. So we normally do it at around between 10 to 30 samples. Once 10 to 30 embryo samples are ready, which takes about 1 to 2 months time. Now we are opening it to the general, our friends and colleagues. They can also send their samples to us and we will do the analysis. So once we do it, we take them out and then we do the library preparation. So we'll vortex the sample. You can see now he's going to vortex the sample. And you have to compartmentalize the PCR. So one is the sample preparation room. The second room is the amplification of PCR room. Third room is reading. So you can't have everything in the same room. You have to compartmentalize you. Otherwise, there will be a contamination of the sample. So you compartmentalize and then you add the library. So you add the barcode. I told you each embryo, we add the barcode and we add all the nucleotides. And so after that barcoding and nucleotiding is done, then we will amplify the DNA of each of the embryos and then we'll mix it together. After the amplification step, it is mixed. So first now we are doing the library preparation. After the library preparation, this is a PCR machine. They have become very compact now. So each PCR can do around 64 embryos at one shot. So amplification. So you put this and you start the machine. So it will have the denaturation annealing cycle and it will run for 3 hours and it will amplify the DNA. So from 4 base pair DNA, it will at least minimum we need for analysis is 20. So this is known as qubit. So after the amplification, you test the DNA, whether enough DNA is amplified or not, because otherwise the result will fail. So this is one step where it can fail. Once that is done, you create the template. So now this is where all the various embryos, the DNA is pulled together. It's done automatically. The machine pick it up, pull it. Initially, this step could be done also manually, but now it is done automatically. Everything is automated and all the embryos are put and the final chip is made. So you can see now the machine will automatically wash, add, do the template formation and they'll add and the final chip formation takes place. So once the final chip formation takes place, you can see this is the chip which is there. This chip is then put in the sequencer. So now this is the chip where all the embryos DNA is amplified, tagged. Now this goes into the sequencer here in a holder and then we put it in the sequencer and in the night, the machine goes on sequencing. It takes 3-4 hours. After the sequencing is over, it will export the data to the cloud. And then many of my, for example, when we do our NIPT, we have got an association with Yogen company, which is in United States. So the scientists in US will read the data. So this is how we do the analysis and then we give the report. So we can do a lot of things in our lab. We are doing PGTA, non-invasive PGTA, PGTM, product of concept. We can do NGS, we can do expanded carrier screening, we can do Fragile X syndrome screening, DMD screening, HY deletion, BRCA 1 and 2, and DNA fragmentation. So these are all the tests that we are offering. And you can see that the NGS has a lot of advantages. It is all chromosomes can be tested, and more than that, it is accurate in detecting partial aneuploidies, mosaicism, translocation. Of course, it is time consuming and costly to install, but once you get the number, imagine doing 92 embryos at one shot. So once you get the number going, and India is it's like a dormant giant. Once it activates, then no one can stop us. So this is a comparative study between CGH microarray and PGS, and they have shown that the mosaicism is better detected by PGS. So at that, trophectoren biopsy is better than blastomere because it is less easy to perform, minimally invasive. It doesn't damage the embryo that much, but at the same time, it has disadvantages. It's costly, needs skilled manpower, very invasive, has a long-term damage implications. And this mosaicism problem is that you biopsy. So what is the problem of mosaicism? So this is a normal embryo with a trophectoren which is normal and an inner cell mass which is affected. So this is actually an abnormal embryo. But if you take a biopsy, you will get a normal report. So this is called false negative report. That is a normal embryo report, but actually it is a positive embryo as far as the genetic abnormality is concerned. If you transfer this embryo, either you will not get a pregnancy or you will get a miscarriage, or worse yet, if the child goes to term, you may have a trisomy baby. On the other hand, you may have another embryo which has a normal inner cell mass but an abnormal trophectoderm. So if you take a biopsy from here, you will have an abnormal report. But actually this embryo is normal, but you will, based on the report, you will not transfer the embryo or you will discard the embryo. So there's a lot of problem that we may have discarded a lot of normal embryos in the past. So remember again this diagram that I told you. Unfortunately for us, the mosaicism is only 5.8%. Most of the time you can classify the embryo into euploid embryo or aneuploid embryo based on how much is the rate of aneuploidy, and this is how we classify euploid, aneuploid embryo. Again, the graphs are there. I'll just show you one of these embryos. So if you can see here on the lower graph, so at 2 level, all the embryos are aligned, but at the level of chromosome 18, the embryo, there is an additional, the embryo has got an additional DNA material about 2. So, but it is between 2 and 3, it is less than 30% level. So it is known as a low mosaic embryo. On the other hand, if you look at it here, you have got a 47 plus 18. So you have got normal, all the embryos are aligned here, and 18 chromosome, the DNA is at 3 levels. So it has 2 is normal, 1 more DNA is added. So this is a trisomy 18 chromosome. So this is very easy once you understand, and based on this you can actually decide which embryos to transfer. I don't want to go into that. This is a website where you can do it. And this is a Santiago Muniz paper where he has shown that in women more than 35 years of age, PGT especially this is called a STAR trial in PGTA really works in patients more than 35, but doesn't work for patients less than 35 years of age. But conventional PGT has the problem of expertise. You need costly equipment. It can damage it. And that is why the non-invasive. So instead of biopsying the embryo, you can take the culture media around the embryo and do the analysis of that embryo and then do the NGS with this. So this is the way which we do. We'll do a ICSI, then we'll from day 3 to day 5, we'll culture it. On day 5, day 6, late day 5, day 6, we take the culture media and then we amplify it. But before as compared to normal standard biopsy where you have got 4 cells, so you have got a lot of DNA compared to the DNA that has leaked up in the culture media. So in this, there's a step between the normal NGS. Before that you do what is known as Malbec. So Malbec is a new technology which was developed by Stanford and Harvard scientists, and in this they have this called multiple annealing and looping based amplification cycle. So it can exactly, but you know, when you have a very low DNA, if you amplify it with a normal amplification cycle, you may amplify the wrong DNA and get a wrong report. That is why you need a Malbec technology which precisely amplifies. The first 5 cycles of the Malbec technology are very graded, and after that the normal amplification is started and then the standard PGS is done. So this is what I was saying, that this is called concordance. So we are now studying what is the concordance. So suppose we take an embryo, we do a culture media, take the DNA and amplify it and do the analysis, and then of the same embryo you take a biopsy also and do the analysis. But which is better? So, you know, because the DNA, someone once said that DNA which leaks out from in the culture media is more representative because it leaks out from all the cells, as compared to the biopsy which you are taking is only of 4 cells. So there's a lot of, but now in the newer studies and in our study also, the concordance rate we have got is around 84%. And this is our preliminary result. So we have done a lot of patients. Now, first child that was born with 4 IVF failures, which I have done, and me and Dr. Nandita, we have, you know, we do a lot of things together. And so what are the next advantages? Embryo remains intact. It's a less strict requirement of equipment, training, techniques, much easier to handle, simple, less likely to be lost. Can we detect PG levels at the genetic level? Comparable with various platforms you can use it. And remember, this is very important. Implantation potential. So please don't mistake it that this technique is PGT, the normal PGT. The normal PGT is a must to do analysis of single gene disorders, etc., etc. This is a technique which is slightly at a lower level than the normal PGT, which can give us an 80% accuracy of the DNA content of the embryo, and which can be used for grading the embryos rather than precisely pinpointing the embryos. Remember that you are grading the embryos. So there are different grading systems that are available now. You have got the non-invasive PGTA, which I told you again. There's another which is visual grading system, which also we have introduced in our lab by artificial intelligence. It's called ERICA, Embryo Ranking Intelligence Classification. It's so superb. Again, you take the photograph of the blastocyst, upload it on the server. The server within 2 minutes tells you which is the best embryo for transfer. You can use a time-lapse IDS scoring as well. And my friend, Dr. Santiago Mune. So when Dr. Mune and Danny Sackar, I remember 15 years back, he came out with a metabolomics, means you based on the pyruvate level in the blood, in the culture media, he came out with a machine which could predict which was the best embryo for transfer. I bought the machine, and then later on the company withdrew the machine from the market because there was a lot of errors and the company went into bankruptcy. But now the new metabolomics has come, which is very accurate. And Dr. Santiago Mine is the man who actually promoted PGTA in the PGT analysis, standard biopsy in the world. He has the maximum report. He is now promoting metabolomics. So these are all grading systems. It is not the accurate. The most accurate system is the PGTM. For thalassemia, you can use this for thalassemia. Single gene disorders, you have to be precise. You have to take the cell. You have to amplify it, how I showed you. You have to do the standard Sanger sequencing, RT-PCR, all you have to do a standard NGS and diagnose. This is for analysis of aneuploidy, which is the best embryo for transfer, grading the embryo. So what is the future? The future would be a combination of time-lapse, artificial intelligence, NICS, that is non-invasive chromosomal screening, and NGS for implantation also. We will be able to do quick NGS. Now we have to take the biopsy, we have to send it to Spain. Now no more. Within the next 2-3 years, we'll have our machine will do rapid. I can take a biopsy on the day 3. I am now doing. I'll say, okay, the blastocyst is developing well. It's a day 3. Is the endometrium good? Great. Why don't we just take a biopsy, send it to the lab? They'll amplify it. They'll tell us whether the receptors are expressed, and day 5 we transfer. If the lab says that no, receptors are not expressed, good, we'll freeze it and transfer in the next cycle. So real-time era, real-time biopsy, that is the future of and that will minimize the miscarriage risk, minimize the chances of birth maximize the chance of birth of a single genetically normal infant without any imprinting or methylation disorders, and with very less obstetric complications also. So this is the future. The future of mankind is in the atom, the bite, the gene, and the virus. Thank you very much.
Thank you so much, Rishikesh, for your informative talk delivered with great passion. And you have explained the concept in a very explicit way, and I can't see any questions in the question box. So thank you once again for your fantastic talk.
Thank you.
Thank you, Lakshmi ma'am. Thank you, Rishikesh sir. It was a great talk. We enjoyed it a lot. We move on to our next session. I now invite Dr. Chaitanya Shimbekar sir to share his experience on the new surrogacy guidelines. To chair the session, I invite Dr. MC Patel sir and Dr. Hitesh Bhatt sir.
Thank you. We all know that ART bill is passed in Lok Sabha, and before this bill passed in Lok Sabha, hello, am I audible?
Yes, sir. Yes, sir.
Yes, sir. Yeah. Before this bill passed in Lok Sabha, there were so many protests from Foxy, from ISAR, from IFS, and individual also. So government thought to hear all this protest and complaint, or rather suggestion, and he formed a standing committee, Raj Sabha committee. And before that committee, all these suggestions were addressed. And that committee invited so many people from our Foxy also to address this problem and to discuss this problem and which kind of amendment should be there before this bill goes to Rajya Sabha, because yet it is to be passed in Rajya Sabha. Then after it will go for signature of Honorable President, and then only it will become act or law. So for that, this type of hearing are arranged at a regular interval. And one of them was our today's speaker, Dr. Chaitanya Shimbekar. Chaitanya Shimbekar was invited as an expert in the field before Standing Committee of Rajya Sabha to express his views about this bill which is passed in Lok Sabha, and which kind of suggestions one can put or should be there to have practice in a better way and in effective way. So may I invite Dr. Hitesh Bhatt, my co-chairman, to introduce Chaitanya Sembekar to express his views and his experience before this Standing Committee of Rajya Sabha. Dr. Hitesh Bhatt.
Has Dr. Hitesh?
No, I think MC Patel sir, Hitesh has not logged it.
No problem. I can carry on. So Chaitanya Sembekar, based at Nagpur, CMD Omega Hospital Private Limited, past president Nagpur OBGYN Society, chairman Infertility Committee AMOX, executive member Maharashtra ISAR, member Infertility Endocrinology Endoscopy Committee FOXY. Long list of his achievements. But before overall all this is credential. He is good, gentle person and good friend of mine, just like my younger brother. So over to Chaitanya to express your experience and view which you had before Standing Committee of Rajya Sabha. Chaitanya.
Thank you, sir. Thank you.
Chaitanya,
Thank you, MC
I would
Patel,
like
sir.
to add to your biodata. I am really proud of you. I have seen his working so hard and passionately, and over the years I have seen him growing in his field, and happy to see you at this position. Chaitanya, keep rocking.
Thank you so much, Lakshmi madam, and thank you, MC Patel sir. It's a short discussion on my experience with the Rajya Sabha Select Committee meeting. The word surrogate has its origin from the Latin word surrogatus, which means a woman acts as a substitute for another woman. Now, the government of India in 2015 on a Lok Sabha start question had a very clear view that government did not support commercial surrogacy. So this is very clear that government is not supporting commercial surrogacy. Now I'll just tell you a story of Shubhangi and Rupesh, and listen to this story carefully. Shubhangi is clerk in BSNL and Rupesh lecturer in Science College. They got married and conceived within a year. And Shubhangi had bleeding at 36 weeks. It was APH, obstetric hysterectomy was done, and baby died after the birth. It was a big blow to the couple and family. 2 saal baad kya hua? 2 years, couple and family were in shock. And then Shubhangi's mother asked her daughter-in-law Karuna to help Shubhangi with surrogacy. Now just listen to this carefully. This is a situation, especially in India. Karuna had no choice but to go for surrogacy. Somehow surrogacy failed. And it was the year of 2015. They were lucky that commercial surrogacy was possible. So they came to us, and she conceived with twin daughters. Surrogate was a primary teacher. She was from a good family with a 12-year-old son, wanted to pursue higher education. And Shubhangi is still in touch with Asha, surrogate who brought Ashaka Kiran in her life. So there are always two sides of every story, and this is something which I just wanted to convey you. So if you look at all over the world, the situation of surrogacy is very interesting. In most of the European countries, surrogacy is banned. In US, there is a mixed type of reaction. Some of them, they have altruistic, some of them they have banned. And most of the places, commercial surrogacy is allowed. In Australia and in Canada, only altruistic surrogacy. In Brazil, the surrogacy is allowed till second degree consanguinity, and in India the law is still to come, but it will come soon. Now the surrogacy is a third party reproduction which can involve as many as 5 people, and that is really interesting. So there are many legal issues related to surrogacy. There are many court cases all over the world, even in India, and there is a very interesting case of baby Manji it was a Japanese couple who came to India for surrogacy, and they get divorced. So that lady disowned baby, and law does not allow father to give a custody. So the father came to India. He ultimately adopted the baby and went to Japan. So this was really something which happened, and there are many such cases. There is a case of baby Jessie where custody was sought by 5 parents: genetic mother, commissioning mother, surrogate mother, commissioning father, and genetic father. So many people wanting surrogate custody of a child. So if you look at the situation in India, there was a bill which was passed in Lok Sabha in 2019, and it is this bill which we are now discussing today. So this surrogacy bill, there were many amendments from time to time. In 2016, they banned cross-border surrogacy and even commercial surrogacy. In 2019, commercial surrogacy was totally banned, and only altruistic surrogacy with close relatives was something which was proposed. And there are many objections to this, and therefore a Rajya Sabha selection committee was formed with Shri Bhupendra Yadav as chairman of this committee. It was formed in November 2019 with Dr. Vikas Mahatme, a very famous ophthalmic surgeon who is a Rajya Sabha member, as one of the members, along with 23 other members. And this committee tabled their suggestions on 5th of February 2020 with the suggestions what they wish to go for as far as surrogacy is concerned. I personally received a letter from Rajya Sabha secretary inviting me for the meeting of stakeholders to put my views on surrogacy bill. It was in December I got received the letter, and I was invited at a meeting in January at Taj Santa Cruz, Mumbai. Here I was invited as an IVF consultant, and I was definitely in favor of compensated surrogacy. But there were many members who were invited, members of Bharatiya Stree Shakti, Advocate Meera Khadakkar, who is actually a retired judge of family court, and Dr. Manisha Kothekar, a Samiti member, were invited. They were totally against commercial surrogacy. Dr. Arun Gadre, a very famous activist from Pune, was called. He is of the opinion that surrogacy should be banned. And Mr. Vikas Karnik, a man who runs a surrogacy center, was called along with a surrogate mother, and they were of the opinion that surrogacy should not be banned. So actually my opinion was our opinion, because I discussed this with Foxy leaders, Rishikesh Bhai, Jaideep Tang, MC Patel sir, and many other experts and medical legal experts. And I will put my views, what I actually said and what we feel as an organization. Our feeling is that surrogacy is important in some situation and should not be banned. And finally, I'll discuss how the golden mean was achieved. So if you just look at the ethics of hiring a gestational surrogate, in situations like agenesis of uterus, there is only option, and that is to go for a surrogacy, and that is a good option. But there are many other indications for surrogacy apart from the agenesis of uterus. But if you look at this study by which appeared in Human Reproduction, it says that only 26% of the people, they prefer surrogacy as against IVF. That means it is not done by choice. Surrogacy is not choice of many people. This is a point to be noted, because all are not Karan Johar and Shah Rukh Khan, where they do surrogacy just to stay in limelight. And remember, friends, now the new rule says that you cannot do surrogacy if you already have kids. That means Shah Rukh Khan already has kids. He cannot think of going for surrogacy. So this is the situation which we all should know. So why people have problems with surrogacy? Because there are no guidelines, no fixed place, no insurance, no bargain for better wages. And the government view is very clear. Commercial surrogacy is against Indian ethos of life. Selfless Indian women should give services for free. Commercial surrogacy is against nature, and altruistic surrogacy is the only answer. Now let us talk about the issue of reproductive autonomy for women. Reproductive autonomy is not a private issue, it is a social issue, especially in India. And surrogacy remains a method to fulfill this reproductive autonomy. Similarly, if you compare it with commodification of a woman, the question is it really commodifying? Surrogate's autonomous decision to use her own body in a manner she feels fit is, I think, not commodifying. And please don't compare this with prostitution, because prostitutes sell their body for sexual satisfaction, while gestation carrier aims to bring child in the world. And this is actually a noble gesture on the part of a surrogate. And someone may say that organ cannot be sold because selling organs is against human dignity, but uterus in this situation is not being sold, it is simply rented, and this seller retains the possession and the use is really temporary. Now, the payment for surrogacy is actually for the termination of parental rights. We allow men to donate sperms and women to donate ova, which is actually allowed even in new ART bill. That means they are paid for termination of their biological parents' rights. And similar situation is with surrogacy. Only thing is this happens at the end of the delivery, where the baby is handed over to the parents. So we were in favor of regularization of this surrogacy bill, and the amendments were suggested by me, and these amendments are compensate surrogacy should be allowed, and the amount should be fixed by the government, which can be reviewed from time to time. So you can just fix the amount which can be reviewed from time to time, and compensation to surrogate mother should be given directly to the beneficiary. This will automatically reduce the chances of exploitation of the surrogate mother. In fact, when we were discussing this point with the committee members, the committee members were of the opinion that if at all we go for the compensated surrogacy, then we can actually have a government recognized agencies which can help in providing surrogates to the couples, but this was ultimately rejected. So fixed pay and direct transfer is something which we thought of. There is a thin line between commercial surrogacy and compensated surrogacy. Surrogacy could be classified on the basis of specific intention. Like if the intention is to earn money, it is a commercial surrogacy. But if it is to render a paid service, it would be considered as a compensatory surrogacy. But both the commercial and compensatory surrogacies were not accepted by Government of India. The committee opinion is that compensation is not allowed because it is a noble act of motherhood where you cannot give compensation. It is not ethical, and if at all it is ethical, then how much should be the cost given? And so the committee says strictly no for commercial surrogacy. They were of the opinion that altruistic surrogacy is good because it is a selfless service. It is a forward step to abolish stigma of infertility from the society. It's a noble act and noble cause, and therefore it should be done by whosoever is interested in helping the infertile couple. Now, as I said, we were in favor of compensated surrogacy and not altruistic surrogacy. But if at all you go for altruistic surrogacy, then our suggestion was that a reasonable amount of loss of wages should be paid to the surrogate. And this is the amendment which we suggested, that the surrogate should also be given a reasonable amount for loss of wages during pregnancy if she would have been working during that time of carrying the pregnancy. So this is a very simple proposal, but it was rejected by the government. So committee says that no payments, it should be strictly altruistic. Now comes the issue of insurance, and we demanded additional life insurance to all the surrogates. This is something which we demanded because I think they need to be protected and taken care of. So the insurance coverage in the initial bill was 16 months. Committee extended this insurance coverage to 36 months, and this is a welcome sign. This is the point which is in favor of surrogates. It's a good point. So they said that now the committee says that you should give insurance coverage for 36 months, and there is no ambiguity as far as insurance is concerned. They are covered everything. They have covered medical expenses, health issues, specified losses, damage, illness, or even death of the surrogate mother. Everything is covered in this insurance, and that is a good thing, which is really in favor of surrogates. So as far as monetary compensation is concerned, it is now totally ruled out. It is out of question, and we now agree to disagree that monetary compensation cannot be given to the surrogates. Now this 2019 bill says that only close relatives can go for surrogacy. Surrogate should be only a close relative. We firmly stressed on this point and requested committee to remove this clause of close relatives, because what is the definition of close relatives? There is no mention of the definition. And the point is that surrogate will be watching her baby growing, making interpersonal relationship more and more complex. This is a serious issue. And if you just look at the close relatives, there is always a problem of coercion. And this is so commonly seen with close relatives, not with the compensated surrogacy. If you have a mother-in-law like Lalita Pawar, Purane Filmon Ki, then you will definitely have the coercion, especially in Indian scenario, kyunki saas bhi kabhi bahu thi, mother-in-law will always play a crucial role, and she will be the one who will be deciding. And just remember my story of Shubhangi. I have told you that Shubhangi's mother wanted her daughter-in-law to go for surrogacy. She actually tried also. This is the situation in India. Now, committee took a very good stand on this point. The close relatives clause is now changed to any willing woman. That means a willing woman shall act as a surrogate mother and be permitted to undergo surrogacy procedure as per the provisions of law. So it is not only close relative, anybody, any mother, any surrogate mother can go for surrogacy and help the childless couple in spite of her status as far as relation is concerned. There was one more point which was important, that the exploitation of lower socio-economic class is something which is taking place with surrogacy. Now we put this point that do you portray domestic help as exploitative, or construction workers who are actually at more risk? So we thought that this surrogacy is not an exploitation because they are actually paid for their services. But this was rejected by committee, and the committee opinion was very clear. Reproductive capacity of a woman cannot be viewed as an economic opportunity. It cannot be looked as a means to earn money. There are many other opportunities given by Government of India especially by our Prime Minister Modi ji. The schemes are really good, and Modi hai to mumkin hai. So all these women should actually avail other schemes to earn money and not go for surrogacy as a method to or mode to earn money. Now, argument which is to some extent true is that surrogacy is only for rich, because affording people can go for commercial surrogacy and poor just cannot think. In fact, they are exploited. Now, I think we need to rise above this class factor, because if you just look at this very good picture, you'll find that rich are actually enjoying life. Poor, they many times are not aware of what is happening in the world, but it is the middle class who is actually suffering. And this suffering middle class, many times even lower middle class people are not able to afford not only surrogacy but even IVF. So our aim is to have IVF for all, and everybody, irrespective of their economic status, should be able to go for this surrogacy as well as IVF if it is required to fulfill their demand of motherhood. So there is one more point. We requested including single women and widows, and committee agreed to some extent. They said that a single woman, divorced lady, and a young age widow who is otherwise capable of having a child but cannot have child can go for surrogacy. So this is something which is a good thing, but at the same time, I personally feel that single parent men and gay couples should not be allowed. I put this point in the meeting and they agreed to this. So now gay couples are not allowed to go for surrogacy. Only a single woman, divorced lady, and a widow can go for surrogacy. Now, some good news. This is a study by Gombak et al. Who says that surrogacy is a good thing because all the surrogate children, it was found that they do well in school. Most of them, they are informed about surrogacy, so they have clear idea in their mind. Birth rate of the surrogate babies is higher than IVF babies. They have good, healthy intrauterine environment which is provided by the surrogates, and surrogates do no harm to the babies. And this has been found that surrogates, they actually take very good care of their babies when the baby is in the womb. And there is one survey which was carried out in India, which says that only 1% of the Indians, they go for altruistic surrogacy. But I'm just hoping that more and more women will come forward for this noble cause, and this scenario will change. Now, 2019 bill says that you have to be married for 5 years to go for surrogacy. Our point was, why wait for 5 years? Because if you have a patient with absent uterus, is it logical to wait for 5 years just because the law says so? And this committee opinion is actually a victory for us, because committee has now rejected this clause, and it is clear that there is no need to wait for 5 years. The intending couple who is married can go for surrogacy if it is really required, and the age which is allowed for surrogacy is 23 to 50 for women and 26 to 55 for men. And this is something which is really a victory for us. Now, there was an issue of foreign national, and this was put by us, and this was point which was well taken by committee. Persons of Indian origins are allowed for adoption. If they are allowed adoption, then they should be allowed surrogacy as well. This was something which we put and committee approved it. Now PIOs can go for surrogacy, but foreigners cannot go. And this is a good point, because foreigners maybe were exploiting the situation in India. Now it is not possible. The age limit for surrogate should be 25 to 35. I think should be no argument for this, because we know that advanced maternal age is associated with many complications. One strong point which was put by me was ART bill should come before surrogacy bill, and this surrogacy bill and ART bill should go hand in hand because they are interrelated. And then even committee members accepted this, and they said that ART bill should be brought before the surrogacy bill. And this is something which I think we all are really happy for this, because ART bill has come before surrogacy bill. Then we will not have any problem as far as surrogacy and ART is concerned. As far as offenses are concerned, we all are witnessing the problems with PCPNDT Act. In fact, Foxy has clear views on the punishments of the PCPNDT Act. Similarly, we tried to argue on this point, but this was in vain. Am I audible?
Yes, Chaitanya, you are audible.
Yes.
Okay. So there was one more point which was, I think, important, that frozen embryos cannot be used.
and they have not changed this
Yes, sir, you're audible.
clause, which was there in chapter 2. But I personally feel that the frozen embryos should be used for surrogacy, because we use frozen embryos in our day-to-day practice. Now, if you just compare adoption with surrogacy, there is no comparison, but adoption babies are not available in India. This is a fact. And if you compare it with uterine transplant, it is too complex, and therefore surrogacy is here to stay. And at the end, I would just like to share what our leaders say. Dr. Nandita Parashadkar has said in Times of India that better surrogacy laws are needed, and there is and you should not ban surrogacy as a whole. Even Dr. Jaideep Malhotra has said that surrogacy is soaring in India, and you should come with the laws which should regulate and promote surrogacy and protect women's rights. Dr. Kamini Rao is actually a member of this surrogacy and IVF ART bill, and she has also said that this bill is unfair to both surrogates and people without children. Dr. Rishma Pai has said that has demanded that you should have more liberal laws. And this is a famous picture of Dr. Naina Patel, which has appeared in Times of India. And according to Dr. Naina Patel, surrogacy should be done in India because we are world leader in the field of surrogacy. Dr. Rishikesh Pai has also said that we need to arrive at a consensus and come out with a good law. And this is something which is the need of our. So finally, what are the suggestions by Select Committee of Rajya Sabha? Select Committee was aware of many organizations demanding blanket ban and a few in favor of commercial surrogacy. So they were in favor of midway, which facilitates surrogacy, but in a regulated way. So in their own words, the other legal aspects attached with surrogacy lies in the challenge of finding a middle or more preferred path by striking a fine balance between the two squarely opposite ideas, because law is to act both as an ardent defender of human liberty and an instrument to distributor of positive entitlements. Further, law must keep pace with the emerging and developing technologies so that their positive benefits could be availed by those in need. So this is how the committee has taken the stand. And so, my dear friends, after a close look at all the points that we have discussed, it is clear that practice of surrogacy is ethically justifiable. Take it as an opportunity to regulate bill. Banning does not help. It is a needed technology for infertile couple, and safeguards to protect surrogates must be in place. It is paradoxical that a very person whom law aims to protect stand even more vulnerable because of the law. So I thank you very much for patient listening. I am thinking of contesting for the post of librarian MSR. So please support me for this. Thank you very much. Thank you.
So thank you, Dr. Chaitanya. And rightly said and discussed all the points. So as per my knowledge, whichever suggestions received by this select committee of Rajya Sabha, just like Dr. Chaitanya has put, almost or about 23 suggestions are under consideration. And with this amendment bill, which is passed in Lok Sabha, it will be amended by these all suggestions, and they will be put before Rajya Sabha. And if it happens so, then it will be little easier for our Foxian friends and ISAR friends to practice reproductive medicine in a better fashion. But let us hope for best. Thank you.
We have a question, sir. Chaitanya sir, we have a question from from Pooja Mehta. Can a person with medical issues and having a child go for surrogacy?
Yes. If the first child is having some medical issue, and if it is certified by the the medical problem which the baby has permits surrogacy, then they can go for surrogacy.
Can I say something?
Yes, sir.
Yes. If it is passed, then there is a provision of two types of certificate, that is eligibility and essentiality. So if a couple is certified that infertility treatment is essential for this particular couple, then they will be allowed. So, and for this type of certificate, there are some grounds, and in one of the grounds is this, that previous child is malformed, or uterus is anomalous, or there is no possibility of natural conceivement. Then in all this situation, appropriate authority will issue a certificate of eligibility or essentiality, and they will be allowed to go for this type of treatment. This is provision in this bill.
Chaitanya, I just wanted to say that we also need to discuss about the transgenders, because after I attended that conference, I really, was quite thing, because they had also involved these transgenders, to participate in this international conference. So according to this law, the transgenders cannot go for surrogacy. So then there has to be some provision for them also.
Yes, even gay couples and single parent men are also not allowed to go for surrogacy.
Yeah.
Only married couple will be entitled.
And single women is allowed, but not single man. Men
No,
are not.
single woman is allowed not for surrogacy, but she's allowed for pregnancy. I mean, artificial insemination. But she's allowed for surrogacy also.
Yes, yes. Widow and divorced.
Ever married. The word is used ever married.
Widow and divorced.
Dr. Hitesh Bhatt sir has also joined. I welcome you, sir.
That panel,
So we now move on to the panel discussion on the new ART bill. As the moderator, we have with us Dr. Manish Machave sir, and as the expert, we have Dr. Jaydeep Tang sir. For the panelists, we have Dr. MC Patel sir, Dr. Hitesh Bhatt sir, Varsha madam, Dr. Varsha Dhawale madam, Dr. Rahul Vani sir, Dr. Rohan Palshetkar sir, and Dr. Parul Savji. I request Dr. Jaydeep Tang sir to please introduce Dr. Manish sir.
In the meantime, Dr. Kalpana ma'am, I have shared a Kahoot link. After this panel, we'll be having a quiz led by Dr. Nilesh Balkavde sir. Everybody can just click the link of Kahoot and enter the PIN code. Thank you.
Kalpana, you can introduce Dr. Manish Machave.
Okay, sir.
And Dr. Jaydeep Tang.
Yes, sir. Dr. Manish Machave sir, he's a gynec endoscopic surgeon from Pune, and he's a chairperson for the Ethics and Medical Legal Committee FOXI 2020 and 22. Dr. Jaydeep Tang sir, he's a Secretary General of the FOXI, and is the immediate past president of the Mumbai Obstetrics and Gynecological Society. And he has many publications in national and international journals. So over to you, Manish sir.
Okay, am I audible?
Yes, Manish.
Yes, sir.
Yeah,
You are audible.
so I'll just allow me to share my screen.
Yes, sir. I have stopped sharing.
Okay, is my screen seen?
Yes, sir.
Yes.
Yeah, okay, a very good afternoon to everybody. At the outset, let me thank Dr. Nandita Palshetkar madam, Dr. Rishikesh Pai sir, Dr. Chaitanya, and all of you for having this wonderful. I received this yesterday, and this is fabulously done, and this is amazingly done. Chaitanya, Nilesh, Rohan, very well done, and it'll help all, not only IVF. I mean, there are so many good chapters about operation theaters which are going to help everyone, not only IVF. So very well done, very good booklet. I pray to Lord Ganesha to sail me through this presentation and this panel. Again, thanks all of you for involving me here. These are the three things which I do: obstetrics, medical legal, and endoscopy. The good, the bad, the ugly. I mean, you can put whatever tag wherever you feel like. Medical legal aspects of ART is the panel which we are going to discuss just now. And I heard Chaitanya speak fantastically on the surrogacy bill. The only point which I want to add is it is still a bill. So it is still a bill, and what we are discussing about ART bill, it is still a bill, meaning whereby it has not yet become an act, meaning whereby you are still to follow the ICMR 2010 guidelines or 2005 guidelines, which were amended or modified in 2010. So the basis of ART practice in India today, on 8th of November 2020, still remains the ICMR guidelines, because all these are bills and they have not yet passed, and the guidelines are very much there on the website for all of us to follow. So we have Dr. Jaydeep Tang sir as an expert today, and I welcome all our panelists. Dr. MC Patel sir, he is a past chairperson of Ethics Medical Legal Committee FOXI and past vice president of FOXI. Advocate Hitesh Bhatt, again past chairperson of Ethics Medical Legal Committee of Foxy, and the Amitabh Bachchan of legal, I mean, is too good in, and he's a practicing advocate now in High Court. Dr. Varsha Dhawale, she was a member of State PCPNDT cell, and she is from Nagpur. Dr. Rahul Wani from Navi Mumbai, one of our young committee members of Ethics Medical Legal Committee. Dr. Rohan Palshetkar, Joint Secretary of AMOX just now, and a very budding and amazing person who's really jumping ranks and coming up very nicely. And Dr. Parul Sauji, who's the infertility specialist from Nagpur. So I welcome all of you. The scheme for today, we are going to keep it very simple. We are not going to discuss any sections or section 2 mein kya hai, section 10 mein. We are going to practically discuss what is to be done with common clinical situations, keeping at the back of our mind the law, but giving very clear-cut messages which will help in everybody in their ART or IVF practice. Now, having said that, the litigation areas in ART are very clear. They are related to consent, documentation, they are related to birth of a defective child, and they are also related to donor programs where confidentiality is to be maintained at the highest standard. Now, these are the areas where the litigations, generally strike the IVF consultant. So we are going to, go step by step and see how we can minimize all this. Again, to be, very clear to all the people who are attending, please remember that only and only once the act is passed. Patel sir very clearly said, once the bill is passed by both the houses of parliament, if it is a central act, and it is signed by the president, then it is published as an official gazette, and then it becomes an act, and then it is to be followed. And if you do not follow, there are sanctions. Whenever we read about judgments of Supreme Court or High Court, they are directions. So, and they are pertaining to that particular case. There are definitely notifications which the state governments will come out, and the administrative bodies are supposed to see that everything is implemented properly. So that is the reason why, again, I am stressing to a point that there are no laws related to IVF just now, other than the Delhi Artificial Insemination Act of 1995. And somehow IVF consultants, this is the first time that all these acts are coming up and discussing. Somehow IVF consultants are, whoever I have talked to, they're not very, happy in getting an act in place. And that is the reason why we have these ICMR guidelines, which we are following. But today we'll touch upon them and touch upon the ART bill also. So we will start with common scenario. I mean, anybody can take this question. And so I am a young pass out, and now I think that I should start my infertility practice. So what should I do at this present time? I have a place. I have some say a 3,000 square foot place with me. It is a commercial place. So let us remove the issue of whether it is residential or whatever. I have a commercial place. Now what do I do? Where do I apply? What kind of licenses do I need? We'll start from the basics so that it benefits everyone. Anybody can take. Hitesh, we can start with you.
Yeah. So, first of all, I will give you advice. If you are young and start thinking to start infertility practice, think twice. Then if at all you are determined to do that, there are licenses which you have to take. The one is you have to take the license for the nursing home. If you are in a place where nursing home license is applicable, most of the states have nursing home license applicable, so you have to apply for that. You have to apply for PCPNDT license because you will require a sonography machine. You will have to have biomedical waste registration license because you are going to use that. If you want to have a spirit at your place, you require to have a spirit license for your clinic. You also require to have the license for the drug if you are stocking more than 2 lakh rupees worth drug in your place, because in Mumbai they have taken cognizance of this type particular thing. Otherwise, RMP is free to keep drugs at his place for dispensing. He cannot sell the drug. And if you are keeping some narcotic drugs, then you require a narcotic license to stock the narcotic drugs. These are the basic licenses which you must have at your place for starting a practice.
Okay, and with respect to IVF or ART, do I need to apply something?
At present, yes, ICMR is just enrolling the clinic. So you have to apply for enrollment of the clinic. There is no license given. It is just an enrollment letter. And that is enrollment letter is nothing but the acknowledgement from them that your application is received. Nobody is checking it. Nobody is verifying it. So it is just a enrollment and not the registration per se.
So, rightly said by Hitesh, because ICMR is simply taking application. They do not allot any kind of registration number or registration certificate or registration license. It is simply enrollment only.
Yes. Okay. So the point to be taken is that we need to have all the licenses that are needed to start a nursing home. In addition, you need to enroll yourself with ICMR. The ART bill has a again, it is a bill. So we have to know what is to be done. Our panelists have already told. But we have to also know that the ART bill has a provision of a temporary and a permanent registration. And once the bill becomes an act, then all these things will come into place. So they have a yes.
Just a word. In Nagpur, under the PCPNDT, it is also noted that those who are having IVF centers and those who are practicing ART practices, their list is also displayed in a different manner with the Nagpur Municipal Corporation.
We will, ma'am. There is a specific question and specific discussion on ART and PCPNDT. So we'll come to that. This is just to start with that. I want to start a practice. So these all things, all the licenses, I have to. So the second point of discussion is, I think anybody, Dr. Rohan is there, can take, or Dr. Sauji can take. What are these primary, secondary and tertiary level clinics with respect to the ART bill?
Manish, this is Jaideep here.
Sir.
Hi. Just to bring some controversy into the discussion.
Yes, sir.
In your 3,000 square foot of space, where you want to start an IVF clinic.
Yes, sir.
Suppose you say that since IVF is a daycare procedure,
yes,
I don't necessarily need a nursing home license because this is a daycare unit.
Okay.
What would the legal stand over there be? Because I was on the district quality assurance committee of Mumbai district for several years for MTP, for PCPNDT.
Yes, sir.
And even was a consultant to the ART bill cell, etc. And when this issue was discussed at that time, they said that there's no clarity on this issue, at least in Maharashtra. So it's of course, as way of abundant caution, as you lawyers talk, it's good to get the nursing home license.
Yes.
But would there be any clarity on this issue?
Yes, sir.
For
I will.
example,
Yes, sir. Thank you. You brought this up. It's not just the IVF guys. The issue started with a lot of ophthalm people and ENT people saying that we are having daycare centers. So our patients never get admitted. Although we have an operation theater, but our patients never get admitted. So when this thing went to Pune Municipal Corporation here, it was an extensive discussion. But they said, even if you have one bed, even if you have a one IPD bed, you have to take nursing home registration license. That is what, the authorities told us. Anybody, yes, Hitesh, you can.
Can I? Yeah. So
sure.
the thing is, what makes a place registration required? It is the indoor, whether you are making patient indoor or not. It is not outdoor procedure. For outdoor, the registration is not required. Now, what is indoor? That is the second question. The indoor is where you require to make patient lie down. Whenever you take patient to OT, it is always indoor. Whether it is for 3 hours, 4 hours, or 2 days or 1 day. It is indoor when you are taking patients indoor. Outdoor is just space you are seeing patient and let patient go. So that is the measure, and that is how even NABH is requiring that now as a quality control. When you require to make patient indoor or operate inside, you make them lie down for any procedure. That is an indoor procedure, and you have to do it because all OTs are indoor basically.
So
it is not outdoor.
that is the basis of what was discussed here, and all the IVF ophthalm guys also. There are so many ophthalm guys who close their clinic at 6 p.m. and go home, in spite of doing cataract surgeries in the morning.
And I will give you once in a year, if you suppose patient is having some problem, you have to keep the patient, you have to watch the patient for observation also. So you should have that facility when you have operation.
So thank you, Jaideep sir, for bringing out that point. But this is the answer. Okay, so the next point was there is mention of some primary, secondary, and tertiary level clinics in the ART bill. What are these? And I'll tell you why I asked. Because if you know what this is, then every gynecologist clinic comes into the ART bill. Okay, so it says that the primary level 1 clinic is the one where preliminary investigations
Basically,
are done.
investigations are done, but the gametes are not taken out of the body, be it the
Correct.
sperm or ovum. The
Correct.
secondary level is the place where we deal with the male gametes, the sperm, like IUI is being done or sperm bank is there. That is level 2. And level 3, the tertiary one, is the one in which the highest level of infertility treatment is taken care of, where we are dealing with ovum also and sperm also.
Yes, correct. Thank you. So my point of bringing this question was, now if you see primary level 1 infertility clinic as per the ART Act, ART bill, where preliminary investigations are done, infertility is diagnosed, nobody handles sperm or oocytes outside the body, a consulting room, general hospital. So that means that all gynecologists, every gynecologist who's seeing an infertility patient comes under ART. Am I correct?
Yes.
Right.
Yes,
So primary level 1 clinics, although level 2 and level 3 clinics have very stringent requirements, level 1 clinic do not have such stringent requirements, but all these clinics do come under that. Okay, we will come to PCPNDT and ART, which Dr. Varsha madam was discussing. So, okay, the presumption made under ART bill is something different. The ART bill makes a presumption. It says once you are registered under the ART bill as the ART clinic, it automatically means that you are registered under the PCPNDT Act. Whereas the PCPNDT Act is silent on this. So as of now, as on today, because it is still a bill, as discussed by the panelists, you have to take a PCPNDT. Now, if you take a PCPNDT and the bill is only there, what forms need to be filled is my next question. Rahul, you can take. So what forms do I need to fill? So I am generally, basically what I am doing in my infertility clinic, I'll simplify it. I am doing a transvaginal scan for ovulation. So it's an ovulation study. Or sometimes I do embryo transfer under ultrasound guidance. So what forms do I'm doing IUI. So what forms and how is this related to PCPNDT?
If you go by legal parlance, the only procedures which are possible of sex selection or sex determination, you need to fill up forms. Now, if you're doing just transvaginal sonography and follicular study, there is no need of any filling up any forms. If you're doing only intrauterine insemination, then the way you should fill up any forms, except if there is a if you are undergoing a process where you are segregating or you are making fractions of X sperms and Y sperms. Now that technology is not available anywhere, so in most of the places, and so I don't think so. Just plain semen preparation, you require to fill up any forms. If you're doing only plain embryo transfers, you don't need to. You do not fill up forms. Only if you're doing PGD or pre-implantation genetic diagnosis, if you are doing only then you need to fill forms, because this is a procedure which is possible to determine sex. So only techniques which can do sex selection or sex detection, only those need to be, those things you need to fill forms. Having said that, the local authorities under their own interpretations are making people fill forms. So it is better to get in touch with your local authority, try to convince him that these do not required. But if he still insists, then you have to probably go against him in the court or follow the instructions.
Okay, so I'll come to you, Hitesh. My one-line answer I want on this. So for ovulation study or follicular monitoring, you need to not fill any F form. Am I correct?
Yes.
Yes.
Yes, Hitesh, you were saying.
See, what I was telling is the confusion is created by the gynecologists themselves. They have told the authorities that these are the procedures of ART. What is ART? That question was asked, and they gave a list of 19 procedures that these are ART. So they allocated the forms. But all ART procedures are not PNDT procedures. That should be kept in mind. Yes. Similarly, all sonographies are not PNDT sonographies. If you are doing echocardiography, if you are doing sonography of a man, it is not a PNDT procedure. Similarly, all procedures are not PNDT procedures, as Rahul had rightly said. Now, they have given reply, say, oocyte retrieval form G. That is oocyte retrieval is an invasive procedure, but not invasive PNDT procedure. There is a difference. Procedure can be invasive, but it is not PNDT procedure. So that is not there in their mind, and that is why all this confusion. And all these rules they have mentioned, none of them says that you have to have form for this particular thing. It is only the local authority that is forcing you to do. There are some authorities, like in Karnataka, they are not asking them to fill all these forms. And Form G alone has no validity. Form G always should be with Form F. Now they are asking to fill only Form G.
So
it is
I
only
agree.
A consent.
So this invasive procedure, amniocentesis becomes an invasive procedure, chordocentesis becomes an invasive procedure. Even if you take out blood for NIPT, that becomes an invasive procedure. But here, because oocyte retrieval is not under PNDT, but the issue is what Rahul said, that you need to talk with your local authority and not fight with them. So this is what, yes,
to the extent amniocentesis, suppose you are doing, or chordocentesis you are doing for treatment, then it is not PNDT procedure. It is not diagnostic procedure. You are doing chordocentesis and putting blood inside for Rh negative mother in the to prevent the anemia. It is a PNDT therapeutic procedure. It is not.
So
for that no form is required.
That is a part of an obstetric scan, and amniocentesis, especially if you are taking out cells and sending for chromosome analysis.
Exactly.
That is what is common. Yes. Now this is why I put this slide, was when we discussed with our appropriate authority, this is what they gave us. And we also tried to argue. In fact, POGS IMA had a meeting with the appropriate authority here. Fortunately for us, they are very good. I mean, they are very helping and they are not harassing any of our doctors. But this is what they gave us, and this is what is now at least in Pune. We request everybody to fill.
Even Manish, you see, our PNDT licenses is as genetic clinic. Now they are asking you to fill Form D. That is for the genetic counseling center. Now, how can you fill the form for which you don't have that category?
Correct. So again, the issue,
Manish,
that is why,
can I
yes,
just come in there? Yeah,
sure.
Sorry, I think you have to understand the backstory behind why authorities insist that we have to fill forms for IVF procedures, which are not currently covered either under the PCPNDT Act, and of course there is no ART bill. This all actually started with discussions in the Central Supervisory Board, where this whole bogey of sex selection with IVF was brought up by a group of activists. After that, there was an RTI which was filed with the government of India, asking about what the government is doing to prevent sex selection by way of IVF. When the government received this RTI, they realized that they simply had no data on it. So they forwarded this RTI to various state governments. And when the various state governments filed a reply, they found that the state governments also did not have any data on this. After that, there was an RTI application filed in Mumbai, where one activist asked, from the children who are born from IVF, how many are males and how many are females? And at that time, a circular was issued to all the nursing homes in Mumbai, where they asked us for our data, saying that you you are doing IVF. So we want to know how many males and how many females were born from your IVF cycles. We replied back by saying that it's impossible to give you 100% data because we do the IVF. The patient does not necessarily deliver with us. We get 30% of our patients come from out of Mumbai. So this is the backstory into how the government started needing or wanting data on IVF. And it is as a way to fill this gap, this data gap, that the government insists that we fill PCPNDT forms for IVF cycles, despite the fact that they are not covered in the PCPNDT. Mind you, I'm not defending the authorities. I think it's a really silly thing to do. They could have just passed a circular or a gazette to say that this is, the right thing to do. But this is the backstory behind this whole thing. In fact, just as you said, we also have excellent authorities in Mumbai. They are very cooperative. And when we went to them with these arguments that you are actually asking us to break the PCPNDT Act, because these forms are not supposed to be filled under the PCPNDT Act, the authorities said, well, you can challenge it in court or you can subject yourself to several inspections. And at that point in time, we felt that, all right, it's okay to fill these forms. So remember that they want to fill the data gap, not that anyone is looking at the data at all. But this was the backstory behind this whole thing.
Okay, thank you, sir. So again, the bottom line still remains, and we maintain that, follow the authorities and be friendly with them. That is. So the point was this, and second was that we discussed about the secondary and tertiary level clinics. Now these have stringent requirements of not only the presence of a particular way in which the interiors are to be designed, what instruments, the people who are going to man all this. So there are stringent requirements for secondary and tertiary clinics, not so for the primary level clinics. And with respect to drug companies, the ART bill is very clear about which drugs are to be sold, which culture media and all. And with respect to all the clinics, ART centers having an ethics committee, and these are the physical requirements. So the sterile area, non-sterile area, embryology complex, we'll run through this. Yeah. So, okay. So we'll go to the next point now. What I have done so far is I have obtained all registrations, as Hitesh told us. Then I have fulfilled space requirements. I have fulfilled staff requirements. All the equipment criteria are there. Next step is consents and documentation. So what are the types of consents that you take before getting the patient to an IVF? And which procedure, and where do you obtain these consents from? Rohan, are you there?
Rohan is not there, Manish. He's caught up with the patient in labor. He just sent me a message.
Okay, sir, no problem. So anybody can take. Where do you obtain? So I've done everything. My groundwork is ready now. I want some consents. I want some paper. From where do I get these consents from?
Manish, can I answer?
Yes, sure, sir.
See, in ICMR 2010 guidelines, there are forms given in the rules, and those forms are basically the ICMR consents. That is form D, E, F, G, H, I, J, K, L. D is for any couple coming for ICSI treatment. E is for IUI with husband sperm. F is for IUI with donor sperm. G is for embryo freezing. H is for tesa-pesa. I is for oocyte pickup and embryo transfer. J is for consent for the surrogacy. K is for donation or the consent of the donor, egg donor, and L is for consent of donor of the semen. So all these legal consents you have to take. Also, you have to take the medical consent, because all these legal consents are insufficient. This is just to establish the right or to give away the right. Like form I of embryo oocyte pickup, or it says my oocyte, my husband's sperm, donor oocyte, donor sperm. So it says that even if it is donor sperm or donor's gamete, the child will be mine. Similarly, the donor consent says even if I give this oocytes to them or sperm to them, the child will not be mine. I will not have any right. So it just establishes or give away the right of on that particular child. But what about the medical part of it? Suppose during oocyte pickup, there can be bleeding, there can be failure, there can be drug allergy. So procedure-related consents also you have to take.
Yes,
these are called medical consents.
Yes, so we can divide it into two parts. There are statutory consents. It's not a statute, but there are recommendatory consents.
Recommended guideline
recommendatory consents, which can be downloaded from the ICMR website. And also you need to have procedure specific medical consent. Right. So that your consents and documentation then becomes good. Now, so I have taken these consents and documentation. How many years do I have to store them? Do I follow the MCI guidelines saying that 3 years, or how many years do I have to store?
No, the ART bill.
As far as the ICMR guideline is concerned, all the record related to ART treatment is to be kept for 10 years.
Okay.
And at the end of 10 years, it is to be transferred to central database. If for any reason center is closed before 10 years, then in that event of time, all the records are to be transferred to central database. And if you are facing any litigation, then till the final disposal of litigation or 10 years, whichever is later. So these are some provision or other guidance from ICM.
Okay, sir. So just an allied question. I started my IVF practice 12 years ago. Now my 10 years record keeping is over. Now there is no place, nobody is taking my records, and those records are there with me. They are occupying a lot of space. So what do I do with those files now?
So up to 10 years, records who have already completed 10 years, you can transfer all those records to central database.
But there is no database. Where is that database? That is the question.
ICMR.
ICMR, is ICMR accepting? I don't know. So maybe Jaideep sir or practicing IVF consultants would tell, is ICMR database accepting your records after 10 years? I don't know. In my opinion, there is no database.
No, they are not accepting.
They are
There
not
are no
accepting
database.
as of now. They are not accepting.
So what do I do now? Because ART is a bill, ICMR is a guideline, MCI is an act. And the act says that after 3 years, you can give a notice and destroy. Yes, Hitesh.
See, you have to write to ICMR because that is the body at present taking care of it. You say that where is the central depository and give us a guidance. You write them once, you write them twice. You can even put an RTI that where to give these records. If you do not receive any notice or anything, any guidance in a reasonable time after your applications, you can give a notice in the newspaper that we are having this record and we are destroying these records of this date to this date. So whosoever is interested can come and collect in 2 newspaper in 2 different language, and then you discard the record after giving that particular notice in a newspaper. There also you have to give reasonable time that I am destroying record after 30 days.
So that is what we do for do for our other records.
Yes, and so for this also you have to do the same.
Yes, so
only
the point
thing you have to add 2 points that you have to inform first the authority where the national registry is.
Okay. Because the ICMR database or the ART database does not exist. That is why I brought this point out. And there are a lot of people who have ART practice of 20 years, 22 years, and then they will have a lot of records to destroy, and they have no place to send these records to.
I will give one more caution here. You destroy the physical record, but get it scanned. That will not. So, if something comes up, you can say I don't have any record. If it is against you, and if it is favoring you, you can present the record. So you are in a safe mode. So you do that.
But Manish, I'd like to just make a couple of points here.
Yes, sir.
My first point is that as of now, there is no nodal agency to regulate ART in India. ICMR was only responsible for creating the guidelines, and it was responsible for creating a registry of IVF centers. The registry in no way implies that ICMR is regulating the IVF centers.
Yes.
Once the guidelines were made, once the registry was made, all actions or regulations will now stem from the Ministry of Health and Family Welfare. So I think it would be fair to say that at this point in time, ICMR is actually quite out of the picture, because the government has taken over all the functions of ICMR, and the government through ART bill and surrogacy bill intends to create new regulating bodies. Okay, so if at all we want to know where to send and who will establish the database, because remember the database in ICMR was to serve as a registry, not to take data on patients, and there is a fairly essential difference between them. And the second point I'd like to make is that I'm not really sure how much space IVF records take. And what is the hurry to destroy records? My nursing home was started in 1966. I have records from 1966 till now. I have not destroyed a single record, although I am well within my rights to do it, as Hitesh has said, after following the procedure. So I have never really understood this desire or need to destroy records. So maybe you should give a thought to also letting people know that it's perfectly all right not to destroy the record.
Yeah, so the issue was if somebody really wants to, and you have big space, sir, we have small space. All right, okay. So all the records consents done. And now I need to procure sperms because I want to get into the AID program. So where do I get sperms from?
As per the ICMR guidelines, you have to get the sperms from a registered ART bank. So right now, there are no registered ART banks. Only a couple of them are actually registered. So ideally, you should get a sperms semen sample from an ART bank, a donor sample from an ART bank.
So the problem is there is nobody, because there's nobody registering the ART center. There's nobody registering the ART bank. So that is problem number one. Problem number two, whoever is running a sort of so-called bank, and that person is having, so that person has to understand. So what is the sperm quarantine thing? Am I, so if I have a donor who comes today and I am the ART bank, am I supposed to quarantine or freeze those sperms, or I can immediately give?
Yes, sir.
See,
6 months we have to keep them in quarantine. 6
keep
months.
whom?
No, if
Yeah,
if
so,
you have followed,
The sample.
so how do you ensure that? So I'm an ART bank. I don't have anything to freeze. I cannot. Where you want? I'm just one office today. I'm just one office today, and I have nothing else.
I think, Manish, as of now, it's my understanding, and it may be perfectly wrong. But as of now, since the ART bill has not been passed and gazetted and notified, you can pretty much obtain your sperm from anywhere, and then you actually are moving into the realm of best practices and following guidelines which are not the law, rather than actually looking at the law itself. So I think you have to decide which sperm bank is appropriate for your needs and procure the sample from there, because the ICMR guidelines, as per my understanding, are guidelines and are not the law.
Yes, sir. So that is why I said that we are basing it on ICMR guidelines, and at the back of our mind keeping ART bill, because it's going to become an act soon. And again, yes, Hitesh sir, I'll come to you. The point is there are few ART banks and who are doing the 6 months freezing and everything, and they are very few. And the issue is that the amount they charge is quite high. So I mean, if you want to go in for quality and the correct person doing it, then the amount they charge is a little high. Yes, Hitesh sir.
See, there are ample number of judgment by the Supreme Court where it is said that when the law is not in place, the recent most guideline from most authentic body will form the basis for deciding the case. That is the first principle of law which we have to keep in mind. So absence of law doesn't make you do anything and everything whatever you want to do. There is a guideline. Now, what is the most authentic guideline? If one person gives it, it has less value. If some association gives it, it has little more value. If some government associated body gives it, it has more value. So ICMR is such body where there is a government association. So that is the latest most guideline 2010 that we have to follow.
Yes.
Now quarantine is.
Manish, can I talk?
Yes, sir.
Yeah. Sir, can I finish?
I have to go. Yeah, yeah. After
Okay.
finishes, I would like to say
something. Sir, please. Okay, yes, sir, you tell, sir.
So basically, I am on the committee of the ART final bill guideline. There are 5-6 of us. Dr. Kamini Rao is there, Manish is there, myself, Dr. Jaideep Malhotra, and there are a lot of others. The final guideline has come to us. I've been consulting with our Secretary General Jaideep Tank also, because I am on the chief of the core committee of the ART bill. I have submitted my final objections, and the committee's meeting in the Rajya Sabha, and the final tabling will be probably done in December. So the new bill has to be followed, not the 2010. The new bill is already on card. It's on the final stage now. Okay, and we have raised 5 objections in the new bill. The first objection I have raised is on the number of oocytes. So 7 number is put, so I have taken that out. I have requested them for that, but I have not been able to. If we raise an objection on that they can donate only once, they will totally go against us. So we have to be with the government. We can't, if we want to change the bill for some little bit, we have to cooperate with the government. So as far as I'm concerned, I have not really gone after the number of times the patient can donate. It has to be one only. It is going to escalate the cost of the donor. But look at it this way, because a lot of the IVF centers in India were overstimulating the donors and using one donor for using it on 4 recipients, and that's why, because of that, 2 donors died. And that's why one of the requirements that has come is that donor oocyte has to be done in a nursing home which has got ICU facilities. So that may be also pushed into so there are 2 parts of the law. One is the law and one is the rules. So when the rules will be formed, we will be able to. So we are trying to. The second biggest thing which I have requested, along with consultation with again Jaideep and all our colleagues, is the imprisonment. The fine for the first offense is 5 lakhs. Second offense is I think 10 lakhs with 8 years imprisonment. So I have requested for decrease in the fine. First offense I have requested 2 lakhs. Second offense 5 lakhs. And third offense I have asked for 6 years simple imprisonment. So this is the second modification I have requested for. I don't know whether they'll accept or not, but I thought that if we go for extreme opposition of the law, then they'll not listen to anything. So, so this bill is now not in the hand of ICMR. It is in the hand of a new committee, which is known as DHR, Department of Health and Research, which is a separate internal cell of the Health and Family Welfare Ministry. So it has been taken out of the hands of the ICMR, and DHA and DHA's officials are negotiating, and that they will be tabling the final bill in the parliament. That is what I wanted to tell you all. Let us all wish that it goes well, but we have a similar law. And I've also, in the offenses, I've made one more request that I said, if there are complications, let's say there's a pickup complication, if there is a death on the table, but due to procedure, then we have got Medical Council of India, we have got Consumer Code, we have got Civil Code. So these offenses should not be tried under the present law. Only those where there's an administrative infringement. That means you took a donor less than whatever is the requisite of the donor or surrogate. Only, or you do a sex detection, only those patients the law should be applied. The rest of the offenses should come under the general application. That also I put. So let us pray to God. Then I think Dr. Jaideep Malhotra has also been asked to give her comments. 5th was the last day of the Rajya Sabha Parliamentary Committee. There, I've also requested that they give us an audience for 2 hours where we can present, because many of them, they don't know the technical aspects of the bill. So let us see what happens. Thank you very much. I have to go for a second talk.
Yes, sir. Thank you, sir. Thank you for your inputs and the things that you told us. And so the whole gamut is that you need to have a ART bank for procurement of semen, for procurement of donors. Yes.
Yeah. So 6 months quarantine is necessary, because otherwise you are putting the person at the risk of getting HIV. And how to cut down the cost? So you have to take first sample on one day from the same donor, You take 30 samples over an entire month. From the last sample, after 6 months, you do HIV test again. So practically you are doing only 2 HIV tests of that person, and you are getting 30 samples. So yes, that way you can cut down the cost.
Yes.
So Hitesh, it might be a little difficult for that guy to produce 1 sample every day on demand.
So I'm just telling.
I know you're just giving an example.
It may be over a period of 2 months, sir. It may be over a period, but from the last sample you get it test after 6 months. That is what I'm talking.
Yeah. No, I agree. But I think
COVID times, nothing else to do. Sample to
I still think that quarantine is important, and if it's possible to keep a track of the donor, it might be a good idea to do a test for all the infectious diseases before you release the samples from quarantine. Now, whether your quarantine period is 3 months, 6 months, etc., that is a matter of best practices, as I said. But a sample at the end of sample collection or a duration of sample collection, according to me, would not really be best practice. You should do a repeat screening of infectious diseases a few months down the line, rather than doing it on the day the person gives his last sample.
Correct. So the idea behind is very good, that you create a database of all the donors. You have a database of semen donors, you have a database of oocyte donors, and then obviously they have to undergo screening tests. The point being that the ART bank is responsible for all this, and they can have commercially compensate the donors, sperm donors, oocyte donors, and even surrogates. And that is the job of the ART bank. And very clearly the bill will also mention that the IVF consultant and the ART clinic should be away from all these kind of commercial practices and allow the ART bank to take over. So now again, we come back to any limit on the number of donations, sperm donations, oocyte donations. And how do you...
7 for oocyte donations.
Yeah, okay. So sir was just discussing that just now. And so there are these numbers which are given, and I think some 70 or 75 times for male, but I think that is for one bank, from one bank. And if that person enrolls in another bank, then one more 75. I think if you take the word of the law, another cycle starts. Okay, so the next question is, can I share gametes and how do I share them? And can I share? That's another thing. So I have.
Sperm we cannot.
Okay. Oocytes, if I have, so I have
for
retrieved.
two,
I have
of the two
retrieved 10
recipients we
oocytes.
can share.
I have
Sir,
retrieved
if
10
we are,
oocytes.
sir,
if you
for
have
one
more
person,
sites,
at least 7 should be available.
yeah.
Okay.
We can share it with 2 recipients, but 7 for every
So very
recipient should have
clearly,
at least 7.
yes. So very clearly, a semen sample should be used only for one, patient, and oocytes can be shared with the, issue that, or with the marking that at least 7 should be available, and that is what even Pai sir was just now discussing.
So the thing is, if you retrieve more than 14, you can share. If it is less than 14, you can't share.
Correct. So
and not
again,
more than 2 couple.
The last sentence on the slide is very important. One should never mix semen samples from 2 individuals. This is what I mean. I have heard. I don't do IVF practice, but I have heard a lot of people do mixing of semen samples, and that is something which one should never, practice. Okay, so this is another question. Very common.
Manish, can I just? I think this clause in the new bill is actually an example of how clauses and laws are not written very well. If you look at this clause, I think it's 27, clause number 27, you will see that one of the things says oocytes from females between 23 years of age and 45 years of age. And it says that we cannot retrieve more than 7 oocytes from the oocyte donor. Now, as an IVF specialist, not as a lawyer, but as an IVF specialist, I will take it to mean that I have to somehow manage the stimulation of this patient such that she will get only 7 oocytes. And out of that, I have to get 7 M2s. So my dosing for the IVF cycle has to be very precise. The other interpretation could be that while I'm doing the pickup, when my biologist tells me that now I have retrieved 7 oocytes, I simply leave the other oocytes behind. Okay, now this is a real classic example of how not to write a law. And this is actually because somebody has copy pasted the wrong sentence from the previous 2010 or the previous ART bill. The previous ART bill said that no woman shall donate oocytes more than 6 times in her life with not less than a 3 this thing, and eggs from one donor can be shared between 2 recipients provided at least 7 oocytes are available for each recipient. It did not restrict the number of oocytes that you could retrieve from that recipient. So someone in the ministry has done a really poor job of doing a copy paste and has completely misinterpreted what the old bill says. And this is one of the things that we have also pointed out when we have said. In fact, Chaitanya, I had also gone to the standing committee of Rajya Sabha during the earlier round of discussion when Ram Gopal Yadav was chairing that standing committee. And just to share my experience at that time, all our suggestions were taken very well. In fact, if you look at the new report, and I'd gone for the surrogacy bill, if you look at the report of the standing committee, all of our suggestions were included in that report. And that report went as a recommendation to the government. And yet, when the surrogacy bill came out, they had completely disregarded the findings of the standing committee. You have to wonder sometimes why they call all these people. They could have just asked Manish or the Patel sir or you or Hitesh to just go through the draft of the act and just suggested corrections instead of flying us all the way to Delhi.
I know, sir. Okay. We'll go ahead. Okay, so now this is a very common scenario which is there in our Indian families. That okay, so elder brother gets married. There's some background voice. Somebody speaking. Yeah. Okay. So the elder brother gets married and for a very long time can't conceive, and the younger brother gets married and his wife conceives and she delivers. The elder brother is still not conceived, and so it is in the family decided that the younger brother will give sperms or the younger sister-in-law will give her oocytes if the case permits. So is it permitted, and what I should do? Parul, you can take this question.
No, sir, it is not permitted.
Okay, so how do you counsel the couple? Because they are very adamant. They say bahar ka kyun lena hai? हमारा ले लो, इनका proven है, ये इनका हो गया है, they have conceived once. So how do you, Parul, how do you counsel this couple?
So as per the law, the donor should be anonymous so that there should not be any discrepancy or litigation eventually involved with the couple or the family members, or nobody should be wanting to take the custody of the child which was born. So it is always better to have an anonymous donor for the same, and that is how we counsel them.
Interpersonal relationship is important.
Yes, Chaitanya.
Yeah, interpersonal relationship is something which is important. So we just try to convince them that this is going to create a problem instead of you might feel that this is good option, but this is not a good option.
Okay.
I will tell you this, because the Indian Marriage Act says that whenever a child is born during the validity of the marriage and within 9 months of the divorce, the child will be legitimate child of the couple.
Yes.
And the DNA matching is the only test which says that who is the father, like Andy Tiwari's case.
Yes.
So that is second thing. Third thing is, if the child is proven to be a child of particular person, he inherits all the properties according to the Succession Act.
Correct.
So now the problem comes. I will give you one example which happened with us. One of the doctor called us. What happened? The brother's semen was put in IUI, and the wife conceived. And after 10 years, they had the father died, and they had a property dispute. That lady filed a case against the younger his brother-in-law, of rape. He said that my brother-in-law raped me 10 years back. I did not give a complaint because my father-in-law was alive. Now he died. I am filing a complaint. And you check the DNA, it is matching. Now that person came to doctor saying that you mentioned, give me a certificate that you have done IUI with my semen in that lady. Now, if that doctor contacted me. Now, if that doctor gives that certificate, what will happen? The police will catch him also for conspiracy in crime, because police will say you are trying to defend him. We expect you to do most ethical practice of not doing the known transfer. And you must have done anonymous. You are defending him by giving this evidence. You are the alibi for him, and doctor will be in a problem. He will face the cases of rape.
lot of
such problems will come.
Yeah,
and that is why
will arise.
Anonymous donor is the only thing which you
okay,
have to
so Chaitanya, I'll ask you this question, because lot of IUI, a lot of AID clinics also face this. So person comes to you and you say, okay, we have to do artificial insemination husband, so an IUI, but the husband is unable to give sample. So for whatever, today is the day syndrome or whatever, those kind of stress related things where he is unable to give sample. Then the couple says, okay, we'll take the container home and we'll get the sample from there. Now, you are not sure, sample is coming from outside. So you are not sure whose sample. Now, how do you tackle this then? Because then again, the issue of suppose they get it from somebody else. So what do you do practically?
Yeah, this is a point which we always face. So what we do is we have a very good room, which is, there is a lot of privacy is there. And we just request them to procure sample in the same room and try to give them as much of privacy and a very good room so that they can have intercourse and collect the sample. Because some people say that we cannot collect sample by masturbation. We need to have intercourse before collecting the sample. So we try to solve this problem.
Can I say something?
Yes, sure. Yes, Varsha.
We have the ICMR guidelines, which are there for IUI husband and IUI donor. So there you can take in writing that this is my sample. The person who brings, the husband can sign, the wife can sign, and the doctor can sign, so that we know that this sample, even if the sample is from outside, but we have a consent with us, which says that yes, the person has signed on this consent saying that it is his own semen. I don't know, the experts may say better, but this is one way in which we can.
Fair enough.
One thing is, if they say that we are not able to give sample, just tell them that we will put an injection and take the semen. So half of them will give if you threaten them with this. And second thing is rightly said by madam, you just take the consent. You take the consent, and this is not joking. This all has worked, because we are taking care of almost 80 centers, and this type of problems have come, and it is negotiated with this type of solutions. And consent, you have to take. The genetic mismatch will not be the responsibility of the clinic. That you have to put.
Yes.
Disclaimer
So,
and Manish, I just want to
yes,
say one thing here, that
yes.
I would see what kind of cycle you are doing in this instance.
Okay.
If you're doing an IUI cycle where the expenses, and if you would like to call it that way, the stakes are not that high, then I would actually tell the patient to go home, keep relations, or come back and try again next day. If it is an IVF cycle, to prevent this problem of them not being able to give a sample for an IVF cycle, and I'm sure all IVF specialists are already doing this, we keep frozen samples, at least 2 as a backup, so that on the day of the pickup, we don't face this problem. So that's, I think, also a message besides the medical legal message. I think that's also a message that should be conveyed to people.
Correct. Thank you, sir. The two options that we discussed, there are some ART centers who will not accept at all any sample which is brought from outside. Fair enough. That is their policy. But there is an option of taking this consent that this is my sample. So you have these two options of tackling this problem. But I know there are quite a few who will not accept, samples being taken from outside. And obviously, there is a lot of issue about confidentiality about the patient's treatment and all. Okay, so my question would be, so we'll start with Parul. So there is this couple who is coming to you for infertility treatment for say 1 year, 1.5, 2 years. Then they disappear and they never come. And then after another 6 months or 1 year, the husband comes or the wife comes alone and says that I want papers because we have a divorce case going on just now. And your papers are going to prove that the problem was in him and it is related to mental issues and physical abuse, so on and so forth. So do you give papers? Do you not give papers? Do you give papers if both of them come, or you give papers only one person comes? What do you do? Parul, what will you do?
So basically, if a person comes like this, a single out of the two partners, they come over. So we don't usually hand over the papers to this single one out of the two as a couple if they come over to us. And so because it is against the law to give the personal information to any of the partners, so we usually don't give this information. And if a legal notice has come and if some legal authorities
that
are
is
asked,
a different thing. So if a notice under section 91 CRPC comes that the police require the papers for whatever reason, that is a different. I am talking about the couple, one of the couple, and that person comes and tells you that there is a divorce case. So it's not that so many times, in fact, the person will not tell you and you don't know and you give away. But here I am putting a situation where the person has told you that there is a divorce case. And I want my papers because those will tell us that, I can prove in the court that such and such thing was there and that caused a lot of mental stress and mental harassment, so on and so forth. So what do you do? One person comes out of the two.
so I think we wouldn't give the papers because it is a personal information and we shouldn't breach the this thing, that we should maintain that thing,
Okay,
and
Parul,
we shouldn't be giving the
we'll
papers.
ask everyone. Yes, Varsha ma'am, what will you do?
In such a situation when there is a divorce and she is under mental stress, I think we can take in writing that the papers are needed for this purpose, take in writing an application from the patient. And after all, the patient has a right to her, she has a right over all that. Whatever we have written, yes, though it is hospital property, she was not indoor, we are giving her as an OPD consent. We have the papers. Maybe sometimes the patient loses the file or loses the important thing. She comes and asks for it. And if we have, we can take in writing that she wants this for such and such purpose and we can give her the papers.
Yes, Chaitanya, what do we come to Rahul, Hitesh sir and MC Patel sir after you tell me. What do you do?
We call Hitesh and Rahul. They are our
Okay. So we'll start with Rahul, go to Hitesh and then MC sir. Yes, Rahul. What do you suggest?
As far as ART is concerned, it is a treatment of both the couples. And when you are asking for records, it is the individual record of the patient herself. If the record is only of herself or the person who is asking for, we can give. When it entitles two individuals, I cannot give the record. You need the consent of the other person also to hand over the records. So if it pertains only to the individual, you can hand over who is asking for the records. If she's asking for a record of the other person or the other partner, you cannot hand over because you require consent of that partner also, unless there is an official notice from the court of handing over. So I would not hand over because it involves two individuals, and the confidentiality or right on the records is the individual record of herself.
Okay, so Hitesh, what do you say?
Yes, Rahul has rightly said. See, Medical Council of India, Section 7, it says that the records should be given to the patient whom you have treated. So if you have done hysteroscopy or some other fertility enhancing procedure on her alone, that record you can give even though husband has signed as a witness. But the forms of ICMR where they both have signed as to give the right or to establish the right on that particular child. These are the legal statutory forms where the husband is signing not as a witness, but as a party to the consent. So all these forms and all these records, you should not give until and unless both of them sign. It is a joint account. So one signature will not do.
Okay, Patel sir.
The same way. If any personal record is related to husband, that cannot be given to wife. In same way, if personal record is related to wife, then it cannot be simply given to husband.
Okay. Okay, right. So I put a very simple situation where the couple tells you. Most of the times they will not tell you that there is a case going on, and they would say, we want to take a second opinion. Please give us all the papers, and you tend to give. Yes, Hitesh, you want to add something?
One more point I would like to add here. There is a case in Hyderabad Medical Council. The point is, if you write something in the diagnosis incompletely, say primary infertility with PCOD, but you do not write oligospermia, that is the husband's problem, because you got some enough number of sperm for IVF. The wife has sued that particular doctor in a medical council, telling that you are not narrating my husband's problem, and he has filed this case against me in the court for divorce based on this. So you are favoring a one party. So please do write complete diagnosis. That is my request to all of you.
Okay, point well taken. All right. So the next situation is that you have a surrogate. Now we'll not
Manish,
go into.
Before
yes,
you move on, can I please excuse myself? I have another webinar to go to.
Sure, sir. Thank you so much, sir.
Thank you. Thank you, Chaitanya. Thank you, Amox. Thank you, MS,
Thank you, sir.
for having me.
So
and
much.
thank you to
Thank
all
you
the
for being here.
panelists.
Thank you.
Thank you. Thank you.
Okay. So, sir, Jaideep, sir, just one thing I want to say before you leave. May I?
Sir, just left.
Okay, sir, no problem. All right. So we'll go to the next situation. We'll not go into the commercial or altruistic or thing. As on today, commercial surrogacy where you can compensate the surrogate is there because it is still a bill. So surrogacy today is going on. Again, even when the bill comes, it becomes an act. I think section 50 says that there will be a period of 10 months given to complete all the previous surrogacies, which will not fall under this category of this act. So any which ways, my question is, you have a surrogate and everything, all agreement done, everything is good. You have insured her and no problem. You have properly compensated. There's nothing. Now she delivers. Now, what do you do with the birth form? What do you write on the birth form that you send to corporation? Yes, Rahul. Yes, sure.
Yeah,
yes,
the ICMR guideline specifically mentions this. The patient has to be admitted, or the surrogate has to be admitted in her name in the nursing home or the hospital, wherever she gets admitted.
Yes.
But the birth record will go in the name of the
patients,
along with the certificate of this mother is acting as a surrogate for us. So along with those papers, you can send the birth record in the name of the commissioning couple.
Okay, so again, thank you, Rahul. Very clearly, he said the patient needs to get admitted in her own name, but the birth record will go with the name of the commissioning parents and with a certificate saying that such and such patient was or such and such person was their surrogate. So this removes all doubts, because we get phone calls every time, there is a surrogate which has delivered. We get this, that, what we have to fill and all. Okay. Okay, this is again something which all of us, all ART consultants have to understand and follow, and probably, you know, discuss amongst yourselves also, and put it up in our societies like MSR, ESAR, you know, and Indian Fertility Society, that advertisements which are made, and you can see big hoardings and big boards, you know, whenever you go to different places, and advertisements like one IVF cycle free on 2 or 3 IVF cycles for 85,000, so on and so forth, are, you know, totally illegal, and you are not supposed to do all this. So please spread this message that advertisements are not allowed. So my question is different. So I want to advertise also without going into the commercial aspect. How do I advertise? Because unless so if I am an IVF center, unless I advertise, I am not going to make people aware that there is a good IVF center. So how do I advertise, keeping in mind the MCI framework or MCI code of conduct? Yes, Chaitanya.
I think you should go for creative marketing.
Okay.
I mean, you should try to, do something for the benefit of patients, or try to educate them. And that is the way you should market, instead of putting hoardings. And that is the wrong way. And in fact, Barsha is aware of this. In PCPNDT law also says that you cannot do marketing of sonography as well. So we took action on few of the centers, because ART also comes under PCPNDT. They are registered under PCPNDT Act. So we took this and we put notice to some of the centers doing marketing for IVF as well, because PCPNDT and IVF, they go together. So they should go for creative marketing instead of, directly putting hoardings and giving schemes.
Okay. Yes, it is.
Yeah. The thing is, the Medical Council Act Section 6.1 says that RMP should not advertise. They can advertise only on few occasions. So when they start a practice, when they change the practice, when they have some free camp going on, when they add some service. So all these are the situations where one can advertise. So yes, that is one aspect. Same ART, this thing says, MCI Code of Conduct says that the advertisement can be done by the hospitals. The hospital can do the advertisement. So what happens? The doctors are basically creating the companies, and those companies are advertising. Say Ambani Hospital is advertising. That is a company. Now Medical Council, they are not member of Medical Council. So Medical Council has no right over that company. So the only point is, the company also should not put the pictures of the doctor on that hoarding, and also should not write the names of the doctor on that hoarding. Otherwise, they can advertise. They have to follow Advertisement Council of India rules, and not the Medical Council of India rules.
Yes. So two very clear points, that hospitals which are companies can advertise. That is one. Second is, the MCI guidelines itself says when you can advertise. So suppose somebody wants to advertise the changing timing or adding of some service, you have brought a new equipment or sonography machine or whatever, or if you are changing premises, you have shifted from somewhere, shifted days or timings, is something, some place where you can advertise. And I completely agree with Chaitanya that use your creative marketing. Don't come into the eye of Maharashtra Medical Council was there. Now you have another body which has come, National Medical Commission. So don't come in the eye of, and IVF consultants do come, because as I told you, we have seen so many hoardings and so many advertisements, and this is not the way. So please spread the correct message. Okay, I think we are coming to the end. We started with starting off an IVF center. We discussed PCPNDT and ART. We discussed issues, consents, documents. We discussed issues related to surrogacy, few issues related to commercial aspects. We also discussed few issues related to the common problems about papers, when to give, when not to give, about what is to be done when you want to destroy your papers, and all those things, without going into much details about the law and act. So before we end, I think I would request all the panelists to give us one tip, so that all IVF consultants will have a good, fruitful practice. And I know the penalty section, I just skipped few slides. The penalty section in the ART bill is, if I may use the word, it's horrendous. And it's all the things which it's in the making of a big PCPNDT Act again. And once it becomes an act, and once rules come, and once the administrative authorities take over, I mean, I'm not trying to scare anybody, but ART practice is going to be very difficult. So before we end, I think all the panelists can give one take home, and then we'll end. So we can start with the senior most, Dr. Patel, sir.
So comply with the provisions of Act, and when there is no Act, then comply with the guideline from ICMR. And if you are in little doubt, then do not hesitate to contact medical legal expert, either Dr. MC Patel or Hitesh Bhatt or Manish Machue, because in any given situation, we are always there to assist our Foxian friend.
Thank you, sir. Yes, Hitesh.
Always think about your safety first. It was a norm in our mind before that we have to see patients good, and we have to take care of the patient at any cost. Please change that mindset. Please say, think about your safety first, and then you take care of the patient.
Yes, Varsha ma'am.
Yes, I would say this is a message to all the doctors who are running the ART centers. Do not go after the quantity. Please go after the quality. Do proper work. Keep your safety. See that you give good results, and see that you don't fall into trouble. That's all.
Okay, Rahul.
Yeah, the ART bill, which is currently passed by Lok Sabha and in the standing committee for the report to be generated. Now, this has a similar clause like PCPNDT, Section 23 of PCPNDT and Section 34 of ART bill, which gives punishment for any violation of any of the act or the rules. I think this should be taken up, and the punishment should be very specific and not so general. Thank you.
Yeah, thank you. This is what you are talking about. It says when no specific punishment is put in the act, it is so much fine and impressed. So this is something which is a blank punishment given in the act. Yes, Parul.
So I would like to say that we should be really prompt with our paperwork, because at the end of it, what is written and what the legal records are going to help us eventually. And all you seniors are going to save us only if we have any documented files with us. So we should do our paperwork very appropriately, and we should take all the consents before getting into any practice, ART practice.
Yes, Chaitanya, you want to say something? Take home from your side.
I think ART people are very much into marketing, and my message is please do not do too much of marketing of IVF and ART. People think that IVF means marketing. I think that is wrong. If you do your work properly, then it is a word of mouth which helps you.
Okay, thank you. And my take home always is, and it always will remain, whenever you speak about your colleagues in front of other people, control your tongue, control your emotions. That is not the place to bash your colleagues. You don't like something about somebody, meet that person, call that person and talk. And what you talk, it just changes the way society looks at doctors. So please be very careful.
Manish, that was my theme on during my presidential year: no medical jousting.
Yes.
So in every program we try to stress on this point that please, because once you discuss about this point, then people realize that jousting is going to harm our fraternity. So yes. No medical jousting, please.
Okay, so thank you, panelists. You were great. I think we finished the panel, I think, very much in time, and tried to cover everything. Thank you, Chaitanya. Thank you, Dr. Nandita ma'am. Lakshmi Shrikande ma'am is there. Thank you, Rishikesh Pai sir. Thank you, Jaideep sir. And all my panelists, you were very good and very clear in your messages, and we never had any controversy. So I'm very happy that we finished a clear and panel where good take-home messages were discussed. So thank you all. Thank you so much.
Manish, I have a question for you. Manish,
yes,
some centers they claim 100% success rate. Is it allowed?
Then
I'm just asking because they really say 100% success rate.
False claims are not good because they attract so many sections of IPC. So I don't think false claims is a good idea. It is not.
And I always wonder how can it be 100%?
A fair success rate with respect to your cases, with respect to whatever is happening around the world, should be good. So 4-5% here and there is acceptable. So somebody saying 40%, 40-45% is good. We are happy because that is fair. but saying 100% is unfair, and it will definitely attract section 40, 420 and 426, 406 of IPC's.
Usually it is posted on social medias. We see many posts
Madam,
from IVF centers.
Madam, those who are doing
Madam,
those who are doing only one cycle in 1 month, and they give 100%, if that patient conceives, it is 100%.
Some N should be limited, and that is the place where actually on a serious note, societies should come. So we have MSR, we have ISAR. Societies should take objection of this, and maybe I would also suggest the societies to have a legal maybe legal help, and then draft a letter and send them, or talk to them initially. Some of them may be our friends. So everything may not be legal. We may give a phone call and say, don't put all this, because it is giving you disrepute rather than any repute. So 90% of the problems with get solved there only. So we can, or then societies should, maybe the president of the society calls up and says, this is not allowed, please don't do this.
Thank you so much, Manish sir, and thank you all the panelists. So we come to the end of our session. It was an excellent session and a great start to the Diwali week, I think. So before we go into the Diwali mood, we have had a very good academic piece today. So thank you one and all.
Thank you, Kalpana, and it was a very nice coordination. And
thank you, sir. Thank you so much. All because of your support, sir. Thank you so much.
Thank you so much, and happy Diwali to everybody. I hope this Diwali brings you health and prosperity, and keeps everybody safe and away from COVID.
I hope post Diwali we are able to see each other.
Yes.
Thank you all, and Dr. Chaitanya in particular, for inviting me to be faculty. So thank you all, and happy Diwali and prosperous New Year.
Thank you, MC sir. Thank you, Manish sir.
Thank you, sir.
Hi, Dinesh.
Lakshmi madam, thank you.
Thank you, Chaitanya sir, for having me as a panelist. Thank you so much, and happy Diwali to all.
And Chaitanya, congratulations, Chaitanya and Nilesh, for bringing out such a fantastic program, and with mind-boggling faculties. All were subject experts. I think Madhuri has logged out. Madhuri, Rishikesh, Amit, and of course our own Manish Machwe, I can see. Hitesh, as usual, fantastic. MC sir, welcome to Nagpur. Thank you. It was fantastic panel.
As Manish has said, may God save you from COVID. For your spouse, you have to take care of yourself.
Yes.
Thank you, Chaitanya sir, for giving us opportunity.
Thank you, Kishore.
Dhanyavad so much, sir. We'll be having more successful. Happy Diwali to everybody.
Kishore and Amit, thank you so much. You have been a big support.
Thank you, Dr.
Amit, due to shortage of time, I think we can't take up the quiz. You have taken lots of efforts, but I think already it's 2 o'clock.
Right, sir.
So we can't take up the quiz right now.
Maybe next time.
Yeah, maybe next time.
And we are giving all the books to all IVF center again, which are left, sir. Thank you. We wish you very, very happy Diwali, sir, to everybody.
Thank you.
Thank you, sir. So with your permission, I'll now close the panel.
Yes.
Okay. Thank you.